The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
All right, guys, now let's discuss legal medicine, medical jurisprudence, and your ethics. First question, which scenario depicts a physician breaching the physician-patient relationship? Is it A, the physician stops seeing the patient after the patient recovers from their illness? B, the physician failed to thoroughly examine a patient during a pre-employment physical examination? C, the physician withdraws from the relationship without the prior consent of the patient? Or D, the physician performed an unsuccessful procedure on a patient? Our answer here is letter C, when the physician withdraws from their relationship without the prior consent. Remember that the physician-patient relationship is contractual, consensual, and fiduciary. Therefore, if the physician-patient relationship is a contractual one, any breach in the contract is also a breach in the relationship. So without patient consent and prior notice, a physician cannot withdraw from the relationship, and doing so would constitute abandonment, which is a clear breach in both the contract and the relationship between physician and patient. Now, choice A, which is the patient's or the physician stops seeing the patient after the patient recovers from the illness, is not a breach because the contract does terminate when the patient recovers. Choice B is the physician failed to thoroughly examine a patient during a pre-employment PE. So that represents a failure in the duties and obligations imposed on a physician. However, there is no physician-patient relationship in a pre-employment physical examination. So kasama siya sa mga exceptions of a physician-patient relationship. We'll go through the other exceptions later. Choice D, which is the physician performed an unsuccessful procedure, is not a breach since the terms of both the contract and the relationship do not promise, imply, or guarantee that the treatment will be successful. So ano yung instances na walang physician-patient relationship? So pre-employment PE, for determining eligibility for insurance, when MD is appointed by a trial of the court to examine the accused and to report whether the accused was insane, autopsies, obviously, and casual questions asked in ordinary places ang tinatawag nating ambush consult. So kapag inambush ka sa reunion ng mga classmates mo, random questions in the grocery store ng kapitbahay, these do not constitute a physician-patient relationship. However, even without a physician-patient relationship, meron tayong duties and obligations. So we have to possess the knowledge and skill of an average physician. We have to use that skill and knowledge with ordinary care and diligence. We must exercise best judgment, and we must observe utmost good faith. Now, the terms of the physician-patient relationship does say that we will render medical service. It does not imply that the treatment will be successful. It does not imply that the treatment will benefit the patient, that it will produce a certain result, or that it will not harm the patient. Nor does it imply that the physician will not commit errors in an honest way. So yung choice D natin, which is the physician performed an unsuccessful procedure on a patient. Again, if we look at this, we have rendered medical service, but again, it does not imply, that relationship does not imply that it will be successful or that we will be perfect without committing any errors. Okay, so when can we terminate the contract and therefore the relationship between the physician and the patient? When the patient recovers, if the patient dies, if there is withdrawal of the MD, provided that the patient has consented to the withdrawal, and the patient is given ample time to look for another MD. So for example, if a physician is moving to a different city, hindi naman yun overnight na mangyayari, the physician has an obligation to tell their patients, give them a heads up, give them consent for his withdrawal, and also help in the referral of the patients so that they can be seen by another MD. When the physician is discharged by the patient, ibig sabihin, sabi ng patient, I don't really like this doctor, I would like to look for someone else, then that's a termination of the contract. And of course, death or incapacity of the doctor. other situations where the contract can be terminated when the obligations have been fulfilled. So for example, you hire a doctor for a rhinoplasty, nagawa na yung rhinoplasty, and that was it. That's the end of your contract. In cases of emergency, when the attending medical doctor of the choice or MD of choice of the patient is available, or when there is cessation of the condition of emergency. Expiration of the period if the contract of the medical service is for a specific period. So for example, yung agreement you with the physician is that they will be your physician for exactly 2 months, tapos na yung 2 months, and that's the termination of the contract. And a mutual agreement between the MD and the patient. So let's say the MD and the patient agree na I don't think I'm the best doctor for this. The patient says, yes, doc, I agree. I think I need to look for somebody else. It's a mutual agreement between them, and therefore their contract is terminated. Next, which inherent right of a physician is upheld when one performs resuscitation on an unconscious patient? Is it A, the right to choose patients? Is it B, the right to perform certain services? C, the right to consent? Or D, the right to determine appropriate management procedures? So the answer here is letter D. So remember, it is a physician's inherent right to determine the appropriate management, including resuscitation, based on the doctrine of superior knowledge. Choice B is an incidental right and includes being able to perform certain procedures based on your specialization. Choice C pertains to the rights of the patient and not the rights of the physician. The physician can be a surrogate decision maker if there is no one else, no next of kin to give consent for the patient. So again, choice D is correct based on the doctrine of superior knowledge. Choice A, which is the right to choose patients, is not the most applicable here because this patient is performing, this physician is performing resuscitation, suggesting this is an emergency. So without potential harm to the patient, ibig sabihin, hindi naman mahaharm ang doctor sa pag-perform ng CPR. It's not a burning building. There's no terrorists in the area, for example. The physician must respond. Choice B, again, is an incidental right, and choice C pertains to the rights of the patient and not the rights of the physician. So let's review the rights of a physician. So remember, they can be either inherent or incidental. So inherent, we have an inherent right to choose patients, except in emergencies. Kapag may emergency, somebody collapses and needs CPR, we must respond, even if hindi natin pinili yung pasyente na yon. Exceptions, if there is threat to the doctor. For example, it's a burning building, there's a patient inside who needs to be saved or who needs resuscitation, we are allowed not to respond because that would pose a threat to our health and our safety as well. If during an epidemic, however, like COVID, we do need to respond, even if responding to the epidemic, so treating patients with COVID, represents a threat to our personal health and safety, we still need to respond in those situations. We have an inherent right to limit practice. We have an inherent right to determine appropriate management procedures. And we have an inherent right to avail of hospital services. Incidental rights, right of way while responding to call of emergency. Exemption from execution of instruments and library. So for example, may utang ka and the court wants to foreclose your properties kasi kailangan mong bayaran yung utang mo to the bank, for example. Your instruments and library are exempted. So your stethoscope, your medical books, hindi nila pwede yung i-seize because that is an incidental right of a physician. You can hold certain offices. You have an incidental right to compensation, to membership in medical societies, and to perform certain services. Okay. Next question. Dr. A posted derogatory statements online against Dr. B without justifiable reason, which is true. A, Dr. A is committing slander and their license can be revoked. B, if found guilty by the PRC, Dr. A can be penalized with a fine. C, Dr. B can recover damages from any mental anguish or social humiliation they suffer. Or D, Dr. A is not guilty of any offense if the derogatory statements are true. Our answer is letter C. So bakit mali ang letter A? So Dr. A is committing slander. That's incorrect. The Dr. A is committing libel. So remember, slander if the statements are given orally. Libel if the statements are in writing, whether or not they are in physical writing or online. Libel yan. If found guilty by the PRC, Dr. A can be penalized with a fine. So why is this wrong? Remember, the PRC has no right to jail time. It has no right to impose a fine. It only can warn, reprimand, suspend, or revoke your license. It cannot either imprison you or penalize you with a fine. Choice D is wrong because regardless of whether or not the derogatory statements are true, as long as they are derogatory, you can still be charged with libel. So even if you post something online and totoo naman, but it is derogatory or defamatory, you can still be charged with libel. Okay, so bakit correct si letter C? Because if Dr. A is found guilty in a civil case, remember civil case, bayaran. Kung criminal case, jail time, kulong. Dr. B can recover moral damages for any mental anguish or social humiliation. And again, it is a case of libel kasi in writing, slander kung oral. Okay? Now, liabilities of physicians and actually of anyone really, remember it can be criminal, civil, or administrative. Criminal, gusto kang ikulong. Civil, gusto kang imulta. Administrative, gusto kang alisan ng lisensya. Okay, so the criminal cases are based on the revised penal code. Civil cases are based on the civil codes and the family code. And administrative cases are based on the Medical Act of 1959 and our Code of Ethics as medical doctors. So what amount of evidence is needed for conviction in a criminal case? Guilt beyond reasonable doubt. So you must have an airtight argument against the person you're suing in a criminal court because the penalty is prison or some cases a hefty fine. In civil cases, medyo mas mababa yung needed evidence for conviction. You just need a preponderance of evidence. And the penalty in this case is damages or bayad. So they can be exemplary, actual, temperate, nominal, moral, or liquidated. Kung administrative naman, hindi ka pwedeng ikulong, hindi ka rin pwedeng i-fine, but they can warn, reprimand, suspend, or revoke your license. And if they revoke your license, they must do so after 2 years. So saan gagawin yung trial if you are charged with a criminal case? Sa court, civil case, sa court, administrative case, in front of the Board of Medicine or the PRC. So terms used in court if it's a criminal case, it's People of the Philippines versus Cruz or Flores. Kung civil case, it's plaintiff, which is the person na nagsampa ng kaso versus defendant or yung person na kinasuhan. So it could be Cruz kung kinasuhan ako versus Flores. And administrative is of course complainant versus respondent. Now, ano yung mga grounds natin for reprimand, suspension, or revocation of your registration based on the PMA Code of Ethics? So, conviction by a court of competent jurisdiction of any criminal offense involving moral turpitude. So, let's say nakasuhan ka in a criminal court and you were convicted by a competent judge. In crimes involving moral turpitude, so ano yung mga examples of moral turpitude? Anything that involves vileness or depravity in the private and social duties. Things like abduction, adultery, smuggling, and rape, for example. Immoral or dishonorable conduct, insanity, fraud in the acquisition of the certificate of registration. So, syempre, tanggal ka sa register of doctors in the Philippines. Gross negligence, ignorance, or incompetence in the practice of their profession resulting in an injury to or death of the patient, or addiction to either alcohol, drugs, or even gambling. So those are grounds that the PRC or Board of Medicine can use to reprimand you, suspend you, or revoke your registration. Other things that they can use is if you make false or extravagant or unethical advertisements. The only things you are allowed to advertise are your name, your profession, your limitation of practice, for example, GP versus endocrinologist, your clinic hours, office, and home address. If you perform or aid in any criminal abortion, if you issue a false medical certificate, or if you perform libel or slander. So kung in writing, libel, kung spoken, slander, especially if it is about spreading news or rumor which is derogatory to the character and reputation of another physician. Aiding or acting as a dummy of an unqualified or unregistered person to practice medicine. Ibig sabihin, pinahiram mo yung trodat mo to somebody who is not registered to practice medicine, or violating any of the any provisions of the Code of Ethics as approved by the PMA. So napag-usapan din natin yung damages. So from highest to lowest, so pinakamahal to pinakamura. So exemplary yung highest to lowest ang exemplary to nominal. Moral and liquidated are special damages. Exemplary is this is awarded above and beyond what is expected of that crime because we want to do it to deter other doctors from doing the same. So sobrang lala nung ginawa mo, na sobrang taas din ang multa so that other doctors are given a warning that you should not be doing what this doctor has done. Actual or compensatory, so adequate compensation only for the financial loss suffered by a person as they have duly proven. So for example, if they have proven that they have lost 1 month's worth of income because of your actions, and you would just pay what the actual loss was. So babayaran mo yung 1 month na income niya. Temperate or moderate is more than nominal but less than actual or compensatory. So there was some financial loss pero hindi natin ma-prove with certainty kung magkano yung na-suffer nung pasyente or nung person na nagsasampa ng kaso. Nominal is only a small amount, so there was no substantial loss, no substantial injury, but the law recognizes na may kasalanan ka nga, so you'll pay a small fee. Moral is a special one because it includes physical suffering, mental anguish, fright, anxiety, and social humiliation, as mentioned in the previous stem. Besmirched reputation or wounded feelings, even sleepless nights are counted as moral damages. And liquidated if meron kayong pinag-usapan, pinag-agreean na amount to be given if there is a breach of contract. So this is something that is agreed by both parties beforehand. Okay? Next, after performing removal of a mass, the head surgeon assigned the resident to close up and left the operating room. During the closure, the nurse accidentally dropped a sponge in the patient. The sponge was left inside and the patient eventually developed sepsis and died. The family can sue the head surgeon based on which doctrine? So the answer here is letter B. So yung tanong is, ano yung pwedeng isampa sa head surgeon? What doctrine can we use? So it is vicarious liability. So any fault occurring in the operating room is a fault of the head surgeon under the captain of the ship doctrine, which is under the doctrine of vicarious liability. So choice A, yung doctrine of res ipsa loquitur or the fact speaks for itself. Pwede yun if yung kinasuhan natin ay yung nurse and yung resident na natira dun sa operating room. Pero who we're trying to sue is the surgeon. Choice C and choice D naman, hindi sila applicable in this case. So again, the doctrine of vicarious liability, any fault occurring in the OR is the fault of a head surgeon under the captain of the ship doctrine. And again, choice A, which is doctrine of res ipsa loquitur, is more applicable if the family were to sue the nurse or the resident who left the sponge inside and closed without properly counting the sponges. So reminder lang sa doctrine of vicarious liability, it's responsibility of a person who is not negligent for the wrongful conduct or negligence of another. So vicarious, diba some people say, I will live vicariously through you. So it is us living vicariously through another person. It is us being responsible for the actions of another person. This is also known as doctrine of imputed negligence or doctrine of respondeat superior. So if employer-employee relationship is established, negligence of employee is conclusively the liability of the employer kasi may obligation yung employer to ensure na maayos yung trabaho ng lahat ng employees niya. For example, here in the NHS in the UK, if you sue a doctor, actually the person who will respond is the hospital or the administration of the hospital who employed that doctor. So in addition to the or other things under the doctrine of the vicarious liability is captain of the ship doctrine. As we talked about earlier, the surgeon is likened to a captain of the ship. So the head surgeon is responsible for anything that will go wrong in the operating room. The same way that the captain is held responsible for anything that goes wrong in the ship, even if hindi naman siya yung directly gumawa nung mistake. Borrowed servant doctrine, so remember, employees of the hospital are sometimes temporarily under the supervision and control of another. So for example, if the consultant borrows the service of the residents and the interns, the consultant will be made liable for any mistakes made by the trainees. Doctrine of ostensible agents, so pathologists, radiologists, and anesthesiologists are usually employers, but at the same time, independent contractors. However, most courts consider them ostensible agents. Therefore, the hospitals are still held liable for their negligent act, even if they are typically independent contractors, because usually they are still employees of the hospital. Now, choice A, which was doctrine of res ipsa loquitur or common knowledge, this is what we call the thing speaks for itself. Diba? Res ipsa loquitur means the thing speaks for itself. Kitang-kita may sponge na naiwan sa katawan ng pasyente. That thing speaks for itself. That could not have gone in there through any other means than by the nurse forgetting to do a proper scrub count and by the resident failing to do a proper exploration of the surgical wound before closing. So the nature of the wrongful act is very suggestive of negligence. There's no need for an expert to enlighten the case. The common person will know that you're not supposed to leave a surgical sponge inside the patient's body. So what are the elements of res ipsa loquitur? So the event doesn't normally occur unless someone has acted negligently. Unless a doctor was negligent, no normal person would be walking around with a surgical sponge left inside their abdomen. The evidence rules out the possibility that the actions of the plaintiff or a third party caused the injury. So, imposible naman na anesthetized yung pasyente, tapos siya yung naglagay ng surgical sponge on the inside. And wala namang third party involved because this is an operating room. It is a controlled environment. And the type of negligence in question falls within the scope of the defendant's duty to the plaintiff. So, of course, doctors have a duty, surgeons have a duty to ensure that when they close a surgical wound, walang foreign object na natira inside unless it is an implant na sinadya naman to leave inside. So, those are the elements of res ipsa loquitur, and this is not the case here kasi yung kinakasuhan is the head surgeon. Next, which is not a common acceptable reason for referring a patient to another physician? Is it A, presence of other diseases requiring specialized care, B, inability of a physician to see the patient due to emergencies, C, engaging in dichotomous fees, or D, lack of resources in the institution of the referring physician? So our answer here is obviously letter C, engaging in dichotomous fees. So the other reasons are very valid reasons to refer to a different physician. So again, dichotomous fees are unethical. So this is what we call fee splitting for referrals. Ibig sabihin, may kaibigan ka, may batchmate kang endo. Ikaw ay isang IM doctor. Sasabihin ka ng endo batchmate mo, friend, pag nag-refer ka sa akin ng pasyente, bigay ko sa'yo 25% ng PF. Okay, so that's a dichotomous fee and that is unethical. So remember the referral system under the PMA. This says that we should always observe proper protocol of referring. So if you guys are gonna moonlight, you will experience lots of referrals. Either ikaw yung magre-refer or ikaw yung tatanggap ng referral. So the consultant may make another referral but should seek permission from the primary physician. So for example, my primary IM kumuha ng opinion of an endocrinologist. The endocrinologist wants to refer to a nephro. The endo has to ask the primary IM, Doc, okay lang ba? I'll refer to nephro. In making a referral, syempre there should be a clinical abstract and there should be a purpose kung bakit nagre-refer. Hindi pwede na ipapadala mo lang yung pasyente without telling the other doctor what they are expected to do. And a physician shall not receive any commission for referring a patient to a colleague, third person, or institution. Pwede ang nominal gifts, so small value gifts on occasions may be received. Pero yung talagang nag-usap kayo, nagkonsyaba kayo na if I give you a patient, I will get something in return. That is against the PMA referral system. So remember, ang pwede lang or ang ethical lang na medical fees are simple and contractual. So ibig sabihin PF for a private consult, that is a simple medical fee. Retainer, ibig sabihin ikaw ay isang retained physician either ng company or ng individual patient. That is also fine. So the payment is the same regardless of the volume or type of patients. Ginagamit to normally ng mga HMOs or insurance cards. Pero yung things like contingent, dichotomous, and straight medical fees, these are all unethical. Contingent, kapag sinabi natin the fee depends on the success or failure of the treatment. Pag hindi successful, for example, yung operation, hindi kita babayaran. That is unethical. Dichotomous is sharing a fee. Again, napag-usapan na kanina, that is unethical. And straight fee is the amount of medical fee is dependent on the remaining balance when all other expenses have been paid. So ito yung buntis package for OB-GYN patients. So kung ano yung natira sa after mabayaran yung OR, for example, kung nagsa-cesarean section, nabayaran na yung OR fee, yung technical fee, yung room fee, kung ano yung natira, yun yung mabibigay sa OB-GYN. That is also an unethical medical fee. Next, in which scenario will the physician be cited for indirect contempt? So A, Dr. A failed to show up to court due to a family emergency. Dr. B, an expert witness, got fed up with a defense attorney and punched them while testifying. Dr. C refused to testify for a civil case because the travel expenses were not paid for by the requesting party. Or Dr. D, an ordinary witness, was proven to have lied during their testimony. So ang tanong ay indirect contempt. Our answer is letter A. So bakit letter A? A medical witness, so for example, a doctor, doesn't need to comply with a subpoena. A subpoena is an order of the court for you to appear in court only when it is a medical emergency to which no one is available and competent enough for their substitute. So this was a family emergency, not a medical emergency. Ano yung example na acceptable? For example, ikaw ang nag-iisang cardiothoracic surgeon in a very small province. Tapos mayroong medical emergency, pericardial tamponade requiring your expertise. Dahil ikaw lang yung TCVS na surgeon doon, syempre, you cannot just leave the patient. So that is a valid excuse. Kung family emergency, that is unfortunately not a valid excuse. In choice B, Dr. B, an expert witness, punched the defense attorney. That is not indirect contempt. That is definitely direct contempt. In choice C, hindi pumayag yung requesting party to pay for the doctor's travel fees. That is valid because in civil cases, the expenses should be shouldered by the requesting party. In choice D, so ordinary witness si Dr. D tapos nagsinungaling siya, that is not indirect contempt. They are committing perjury, which is a crime. It is the offense of willfully telling a lie in court after taking the oath. So remember, you have to swear on the Bible to say that you will tell the truth and nothing but the truth. So as I said, subpoena is a process to pretty much force a witness to appear before a court and give testimony or produce evidence. So kapag nasubpoena ka ng court, failure to do so is grounds for reprimand, papagalitan, suspension, or revocation of your certificate of registration. So there are different types of subpoenas. So pwede kang isubpoena to testify, so subpoena ad testificandum, or to give documents, duces tecum, or if both, you can also give both a testimony and submit medical documents. So as mentioned, ano yung mga situations where you are allowed not to comply with a subpoena? When the issuing court has no jurisdiction over the subject matter and person of the case. When the place of residence is over 50, although in-increase na ito to over 100 kilometers from the court. So if you live 100 kilometers away, you are not needed to comply. In civil cases, pag hindi babayaran yung iyong travel expenses, and again, when an MD is attending to an emergency, like the TCVS example I gave, or when a physician is suffering from an infirmity which may be aggravated if they comply. So I suppose an example is a patient or a physician who has severe heart failure, and having to travel such long distances may aggravate their heart failure. So that would be an example of when they do not need to comply with a subpoena. Which is a function of the Board of Medicine? Is it A, to determine and prescribe the minimum required curriculum for medical education, B, administer and conduct the PLE, C, promulgate rules and regulations for the conduct of the PLE, or D, general supervision and regulation of all professions? So which is a function of the Board of Medicine? It is to promulgate rules and regulations for the conduct of PLE. So remember, the Board of Medicine is in charge of determining and preparing the contents of the exam you guys are about to take, as well as promulgating the rules and regulations. So yung choice A, which is determine and prescribe the minimum required curriculum for medical education, that is the Board of Medical Education, BOME. Choice B and D, so administer and conduct and general supervision of all professions, are the responsibility of your PRC, or Professional Regulation Commission. So don't forget the different regulatory boards of medical practice. Kung Board of Medical Education, the name itself suggests they are concerned with standardizing and regularizing your medical education. Kung PRC, Professional Regulation, it concerns all professions constituting the highly skilled manpower of the country. So your architects, your engineers, your doctors are under the PRC. They also administer and conduct the licensure examinations of these professions. Kung Board of Medicine, they are responsible to determine the qualifications and fitness of applicants to practice medicine in the Philippines. So that involves determining and preparing the contents of your PLE. Okay. Next, who is illegally practicing medicine in the Philippines? Is it A, an American oncologist doing rounds at a teaching hospital at the discretion of the Board of Medical Education. B, a foreign exchange medical student performing wound suturing while being guided by a surgery resident. C, an optometrist diagnosing error of refraction and prescribing lenses. Or D, a medical graduate moonlighting as a general physician at a clinic a day after passing the PLE. So be careful, guys. The answer here is letter D. Once you guys pass the PLE, you cannot moonlight. Huwag niyong tanggapin yung mga posts na nagsasabi pre-board accepted. That is an illegal case of practicing medicine in the Philippines. So again, you cannot legally practice medicine kahit na nakapasa kayo ng PLE, kahit top 1 kayo sa PLE, until you have a valid certificate of registration with the PRC. So moonlighting is definitely considered a practice of medicine, and doing so before you are duly registered is illegal. Choice A is considered limited practice of medicine. So yung American oncologist na nag-rounds with the blessing of the Board of Medical Education, that's okay. Choice B, nag-suture under the guidance of a surgeon, yung medical student. So this is not considered practice of medicine kasi there's supervision by a registered physician, and the student is only doing one act, the suturing. Choice C is not considered practice of medicine because the act is considered the practice of optometry. So itong optometrist diagnosing error of refraction, that is within their remit as optometrists. So remember, prerequisites to practice medicine, you must be at least 21 years old. You must have passed the board examination. So again, dapat average score of at least 75 and walang subject na below 50. And even if you have done all of these, you need to hold your valid certificate of registration. You need your license to practice. Okay. Now, what are acts considered practice of medicine? So if you, for a compensation, fee, salary, or reward, will examine, diagnose, treat, operate, or prescribe any remedy, if you make signs, cards, or advertisements as a means to diagnose, treat, operate, or prescribe any remedy. So if nag-TikTok kayo, calling yourself a doctor and giving information about diagnostics and medical practice, or if you use the title of MD after your name na hindi pa naman kayo nakapasa ng PLE or hindi pa kayo registered, that is considered practice of medicine. Not considered practice of medicine is any medical student or graduate under training under direct supervision of a registered physician. So yung case of a surgical intern performing suturing under the supervision of a registered resident, that is not considered practice of medicine, and that is legal and allowed. Any person rendering service gratuitously in cases of emergency, so things like first aid or bystander CPR, that is not considered practice of medicine. Or any person who administers household remedy as per classification of existing pharmacy laws. So as long as it is within the remit of the pharmacy laws, it's okay to give your household remedies. Other things are duly registered healthcare professionals practicing within their scope of their field. So a dentist obviously can give antibiotics for dental abscesses. A masseur or physiotherapist can obviously give physiotherapy exercises. Optometrists, psychologists, and prosthetists can do things within the scope and remit of their field. There is also a limited practice of medicine. So physicians from other countries with authorization from the Board of Medicine for specific and definite cases, attached to the international bodies or organizations to perform certain definite work in the Philippines. So meron tayong mga international organizations like Doctors Without Borders, and they only perform specific work in the Philippines. That counts as limited practice of medicine, and pwede yan. Commissioned medical officers of the United States Armed Force serving in the Philippines, given they only serve members of the armed forces and within the limit of their territorial jurisdiction. So for example, within their medical base or in their military base only. Foreign physicians employed as exchange professors in special branches of medicine or surgery, and medical students who have completed the first 4 years of medical course, graduates of medicine, and registered nurses who may be given limited and special authorization by the Secretary of Health only during epidemics or national emergencies. So based sa mga nabanggit natin, type nyo na lang yes or no, or sabihin nyo yes or no, is it a legal practice of medicine? Nurse na kumuha ng blood pressure ng patient tapos nagreseta ng antihypertensive. So that is not legal because it is a nurse, not a doctor, who is prescribing the medications. Third-year medical student, naglagay siya ng MD sa dulo ng pangalan sa nagsusulat ng chart. So that is also an illegal practice of medicine kasi they illegally used MD. Med-graduate, kakapasa na ng boards, nag-moonlighting, hindi pa nag-oath taking. So that is no, it is not legal. American doctors, pumasa ng boards natin sa Philippines at may license. Nagpakalat ng flyers tungkol sa bagong clinic niya sa Manila. That is, yes, that is legal. They did all the necessary prerequisites to practice medicine in the Philippines. Next, a 25-year-old male was brought to the ER for violent and aggressive behavior. He tested positive for methamphetamine hydrochloride. He was also found to be carrying 10 grams of the substance. If this was his first offense, what penalty can he incur? So the answer here is life imprisonment. So this falls under the Dangerous Drug Act. So remember, if they test positive for a dangerous drug and also possess said dangerous drug, they shall be penalized with possession. And depende na lang kung gaano kadami yung drug na hawak nila to determine gaano katagal yung sentence. So 10 grams of methamphetamine is grounds for life imprisonment. Okay, so choice A, yung 6 months of rehab at a government facility, is for the first offense of a dangerous drug use, not possession. Choice B, imprisonment of 6 years and 1 day to 12 years. To 12 years is second offense of drug use, not possession. And choice D, which is life imprisonment to death, is only if you possess at least 50 grams of methamphetamine. But remember, wala ng death penalty in the Philippines. So when it comes to drug possession and penalties, ang kailangan nyo lang ma-remember ay 10 grams, 50 grams, and 500 grams. For all drugs except for shabu and marijuana, 10 grams yung limit natin for life imprisonment to death. Kung 50 grams of shabu, so at least 50 grams of shabu, life imprisonment to death. At least 500 grams of marijuana, life imprisonment to death. Exception is marijuana resin, which is a concentrated version of marijuana. Mas maliit yung required na amount for it to constitute as life imprisonment to death. Anything less than that ay mas short ang iyong sentence in jail. Okay? Next. Which scenario necessitates an autopsy to be performed on the dead body? When the manner of death is accidental, upon verbal request by the family, to answer questions by the media, or upon order of the local health officer? The answer here is when the manner of death is accidental. So whenever there is a violent death, stabbing or shooting, accidental death, suicidal death, sudden death in a person of apparently good health, death unattended by a physician, so died at home, dead on arrival, or death occurring in unnatural manners, these all should be autopsied. Choice B, which said upon verbal request of the family, so trick question, it should be written request by the next of kin. Choice C, which is to answer questions by the media, that is wrong. That is not a reason for which an autopsy should be performed. And choice D, upon order of the local health officer, is also wrong because they are not included in the list of people authorized to request an autopsy. So who can request an autopsy? So again, nearest of kin if in writing, the Solicitor General, provincial, or city fiscal shall deem it necessary. So for example, fiscal is prosecutor, by the way, in order to get evidence for a criminal case for murder. Upon written request of police authorities, order of the court, mayor, and a provincial or city fiscal, again, this is prosecutor, or whenever required by special law. So walang sinabi about media or local health officer. So choice C and D were incorrect. Next, alcohol causes accidents while driving because there is A, decreased confidence in driving skills, B, increased reaction time, C, increased visual acuity, or D, improvement in concentration. So this is quite an easy answer, obviously. Increased reaction time ang ating answer, or letter B, because the rest, increased visual acuity or improvement in concentration, will, of course, prevent accidents rather than cause accidents. And decreased confidence in driving skills, actually, if you are drunk, you have an increased confidence in driving skills. So again, reaction time is increased. Ibig sabihin, mas mabagal ka mag-react to stimuli, visual or auditory stimuli when you're driving. So choice A, alcohol gives a false feeling of confidence. Choice C is wrong because alcohol decreases visual and auditory acuity. And choice D is obviously wrong because alcohol impairs concentration. So again, increases reaction time, false feeling of confidence, impairs concentration, judgment, and muscular coordination, and your visual and auditory acuity are also decreased.
Next question 92. A body was found with a gun on the right hand and wounds at both sides of the head. On further investigation, the person was found to be right-handed. Which wound characteristic will point towards a suicidal gunshot wound? Is it A, a muzzle imprint on the wound on the right side of the head, B, inverted wound edges on the left side of the head, C, a positive paraffin test on the left side of the head, or D, absence of vital tissue reaction? Our answer here is letter A, muzzle imprint on the right side of the head. So what are things that would point towards a suicidal gunshot? So essentially, a muzzle imprint, a muzzle imprint suggests that that wound is the entry gunshot wound. So if it's on the right side of the head and the patient is right-handed, then it would suggest that it's consistent with suicide because the patient was able to access the right side of their head most easily. So remember, suicidal wounds usually involve areas which are accessible to the hand. And so if the person is right-handed, it would be logical that the entry wound would be on the right. Choice B, which is inverted wound edges on the left side of the head, points away from suicide because an inverted wound is usually a sign of an entry wound. So obviously, if right-handed siya, the patient might shoot themselves on the right sides of the head and then lalabas on the left. So the entry wound should be on the right and not on the left. Choice C also points away from suicide because of the same reason. A positive paraffin test is usually seen on your entry wounds rather than on the exit wounds. Furthermore, choice D, which says absence of vital tissue reaction, suggests that this is a post-mortem wound. So that would definitely point us away from suicide because a patient would not be able to shoot themselves if they were already dead. So post-mortem means that that wound was likely inflicted after death. So some key features of entrance versus exit wounds. Actually, this photo is a really good visualizer for for entrance versus exit wounds. So pag pumasok yung bullet, of course, the edges will be inverted within a braided margin. Tapos pag lumabas yung bullet, the edges would be everted and it would be more ragged versus an entry wound na usually mas clean yung entry site. So some key differences between entrance and exit wounds. So the presence of wound always present kapag entrance, definitely. Exit hindi always present kasi it's possible that the bullet is lodged inside or stuck somewhere inside the body. The size of the bullet in comparison to the skin. So sa entrance wound, it's usually smaller versus sa exit wound, it's usually bigger. The edges, again, are inverted sa entrance and everted sa exit. The shape is usually oval or round, versus in the exit wound, it does not manifest to any discrete or specific shape. It can be stellate or ragged. Contusion or abrasion color can be present due to bullet contact and is absent in the exit wound. Tattooing or smudging can be present with near fire, but is always absent in an exit wound. Underlying tissues do not protrude kasi syempre paloob nga yung force versus in exit wounds where they can be protruding. Paraffin test may be positive in an entrance wound, depende kung gaano kalapit yung gun during the shooting, versus in an exit wound where it is always negative. So those are the entrance versus exit wounds. We also have to note the antemortem, meaning before death, versus postmortem or after death wounds. So generally, medyo intuitive naman siya, definitely hemorrhage, mas copious and arterial sa antemortem wounds because the heart is still pumping. So there can be spurting and there can be clotting. Versus in postmortem wounds, the bleeding is always venous kasi the heart is no longer pumping. So kung ano man yung lalabas from the wound, it is just from whatever blood is left in the veins. There is usually no spurting of blood and there is no clotting as well. The edges of antemortem wounds are usually deeply stained and cannot be removed by washing, and that the opposite is true in postmortem wounds. The edges are gaping in antemortem wounds because you still have alive skin and fibroblasts and muscle fibers, so they pull at the wound edges, and that makes the wound gaping. Versus in postmortem wounds, wala na yung contraction and yung elasticity, so the wounds do not gape, and you can closely approximate them to each other. So things like inflammation and reparative processes, so formation of granulation tissue, for example, would of course be present in a person who is still alive and would be absent in a wound that was inflicted after the person has already died. Okay? Next, a female physician forcibly rubbed the genitals of a 20-year-old male during examination. Unbeknownst to the patient, the physician was married. The physician can be charged with A, rape, B, seduction, C, acts of lasciviousness, or D, adultery. Our answer here is letter C. acts of lasciviousness. So essentially, kapag acts of lasciviousness, we are looking at the use of force and the performance of an act which will excite lust. So in this case, yes, there was use of force, and yes, there was an act which will excite lust, which is the rubbing of the genitals. The offended and offending party can be of either sex. So a female can perform acts of lasciviousness on a male. Choice A or rape is wrong because there is no carnal knowledge. There was no intercourse. There was no insertion of anything into any orifices. Choice B is wrong, which was seduction, because again, there was no intercourse. And choice D is wrong because one, there is no sexual intercourse, and two, the patient did not know that the physician was married. So remember, in adultery, adultery can only be filed against a woman. And one of the elements of adultery is the man must have known that the woman was married. So in this case, hindi naman alam ng pasyente that the physician was married. So don't forget the differences between your different sex crimes. So I'll just quickly summarize them. When it comes to rape, simple seduction, ordinary qualified seduction, or incestuous qualified seduction, there has to be carnal knowledge or sexual intercourse. In acts of lasciviousness, it can be any act which tends to excite lust. So rubbing of the genitals, rubbing of the breasts, those are examples. In rape, in the old rape act, and according to Solis, the offended party is a woman and the offender is a male. So dati, they did not really recognize that women could be rapists as well. Although, of course, in current laws and in current practices, a woman can definitely be convicted of rape pa rin. So again, remember, kailangan ng carnal knowledge and sexual intercourse for the first 4 sex crimes. Pero sa acts of lasciviousness, it is just any act which tends to excite lust. In addition to doing any act which tends to excite lust, there has to be the presence of at least one, either the use of force or intimidation. The offended party was deprived of reason or unconscious. So for example, very lasing or high yung offended party. Or if the offended party is under 12 years old, so they definitely could not have consented to that act. Crimes of chastity, so adultery versus concubinage. So in the Philippines, we do have really archaic laws about crimes of chastity, but we have to discuss them here. So remember, only the wife can be charged with adultery and only the husband can be charged with concubinage. It is so much harder to prove concubinage and it is much easier to prove adultery. So the laws are really stacked against women in the Philippines. So in order for a wife to be convicted of adultery, all of the following have to be present. So first, the woman must be married. So what if, Doc, they're not annulled, they're still legally married, but they've been separated for 20 years and they've not seen each other for the past 15 years, unless their marriage was legally annulled and legally dissolved, that would still be adultery. The woman must have had sex with another man, and the man must have known her to be married. So a one-night stand while the woman is married, and alam nung ka-one-night stand niya, nakasal siya, that is already adultery. Versus concubinage, you can see that the criteria is much more difficult. So one, the mistress must have been kept in the conjugal dwelling, meaning that the mistress must have slept or must have stayed in the shared home between the husband and the wife. Sex under scandalous circumstances with another woman. So dito sa adultery, it doesn't matter kung scandalous or hindi scandalous ang circumstances, basta there was any intercourse, you can be sued of adultery. So concubinage, dapat scandalous yung circumstances, and there has to be cohabitation with another woman. So either pinatulog sa conjugal dwelling or they are living together na hindi pa dissolved yung previous marriage niya. Those are things that can point towards concubinage, which can be filed against a husband. So again, wife, adultery lang pwede. Husband, concubinage lang pwede. Next, a victim suffered lacerations and avulsions to the face, arms, and torso after being physically assaulted. After 5 days of incapacity and hospitalization, the victim recovered but had lost their sight. The offender is liable for A, serious, B, less serious, C, slight physical injuries, or D, mutilation. So what is our key word here? It is the loss of sight. So the loss of sight automatically classifies this as letter A, a serious physical injury. So ignore the number of days that they were incapacitated from work. The only important thing here is loss of sight, regardless of how long they were incapacitated. Matic, serious physical injuries na yan. So remember, any injury resulting in insanity, imbecility, impotence, blindness, loss of speech, loss of senses, or deformity is considered a serious physical injury, regardless of how long the person was incapacitated from work. Choice B or less serious physical injuries is wrong because there is blindness again. So kahit na tinanggal natin yung blindness, remember 5 days na wala sa trabaho yung pasyente. In less serious physical injuries, kailangan more than 10 days. Choice C is wrong kasi kahit napasok siya sa days of incapacity for less choice C, which is slight physical injuries, 1 to 9 days, there was blindness, so hindi pa rin siya counted dun. Choice D is wrong, obviously, kasi mutilation involves looping or cutting off any part of the living body. So when determining whether serious, less serious, or slight physical injury, the first question you have to ask yourself is, was there insanity, imbecility, loss of sight, speech, senses, or deformity? If the answer is yes to any of those questions, automatically go for serious physical injuries. If the answer is no, that's the only time you will ask yourself how long sila nawala sa trabaho. So this is why, as future doctors, it's really important that you're honest in your medical certificates and assessments. Kasi for example, nabatukan lang yung isang pasyente, sabi niya, Doc, can you write me a sick note so that I can get out of work for 30 days? So kahit na wala naman siyang real physical injury, pero you mark them sick for 31 days, for example, that would already count as serious physical injury. So again, in the absence of these features, ask for how long they were incapacitated. Less than 10 days, slight. More than 10 but less than 30, less serious. More than 30, serious physical injuries. Okay, so again, this is another summary of what I discussed earlier. Next, a child was born 8 months after valid marriage. Prior to marriage, the parents were living in for more than a year already. The child is A, illegitimate since the child was born too early before marriage, B, legitimate since the parents were live-in partners before they got married, C, legitimate since all the requisites for presumption of legitimacy are met, or D, illegitimate since the child is spurious. Okay, so we are using solace in this definition or the old definitions for legitimacy. Our answer here is letter C. So the patient or the child is legitimate because all the requisites for presumptions of legitimacy were met. So what are the presumptions for legitimacy or the requisites? So first, the child must have been born 180 days or 6 months after marriage. And the husband must have had access to the wife to the first 120 days of the 300 days preceding birth. So let's explain what this means. Pero for the purpose of the boards, just remember 180 plus 120 equals 300. Those are the 3 dates that you need to remember. Okay? So let's go back to this case. 8 months, ilang days yan? So 8 times 30, that's about 240 days. The child was born 180 days after marriage? Yes, correct, 240 days. Did the husband have access to the wife in the first 120 days of the 300 days preceding the birth? So they were already living in for more than a year prior to marriage. So definitely that was, the husband did have access to the wife. So what is this trying to tell us? So essentially, it wants to make sure na if X is the date that the child was born, so definitely the age of gestation, it would have been about 9 months. So 9 months or 270 days, round up mo to 300 days. So conception would have been at day 0. The courts just want to make sure that in the first 120 days, it was possible for the man to have had intercourse with the wife to ensure na sa kanya yung anak. Okay, does that make sense? So let's say the child was born here at day X. They will go back to the 300 days preceding the birth because this is the time that the wife would have been pregnant. And in the first 120 days, which is about the time that the woman would have been impregnated via sexual intercourse with a man, they want to make sure that it was physically possible for them to be together and for them to have had intercourse. So for example, nanganak yung mother dito. They went back 300 days and they found out that in the first 150 days, actually OFW pala yung husband. He wasn't physically in the Philippines. Hindi sila physically nagkita ever in the first 150 days. So hindi siya counted kasi it would have been impossible for the man to impregnate the woman if he did not have physical access to the wife in the first 120 days. Okay? So these are the reasons why the other options are wrong. So choice A said that it was illegitimate kasi the child was born too early. So that's incorrect kasi ang limit lang naman natin is at least 180 days after the marriage. The child was born 8 months after the marriage. So definitely it went beyond 180 days. Choice B said legitimate since the parents were live-in partners. So again, being live-in partners is not a requisite, but it does support the notion that the husband had access to the wife. Choice D is wrong because the child is not spurious since the parents were married, and I'll explain what spurious means. So again, ito yung definitions natin, legitimate children. So na-explain ko na itong 120 plus 180 equals 300, the three number of days that you need to remember. Legitimated children. So let's say na hindi initially legitimate yung children. So the child was born out of lawful wedlock. However, the child is natural. The child was acknowledged by both parents before marriage. And then eventually, nagkasal din yung dalawang parents. They can then be considered legitimated. So initially, they were illegitimate. Ibig sabihin, pinanganak out of wedlock. Pero when they met all these requisites, they can be called legitimated. So adopted, obviously, that is self-explanatory na. Next are examples if you're illegitimate children, okay? So I'll talk about the spurious children kasi yun yung lumabas sa options kanina. So these are examples of spurious children. They are children who are not considered natural. So please note this is a really old definition, but sometimes it comes out in the board, so you need to know. Adulterous children, self-explanatory, either conceived in adultery. So adultery, the wife had intercourse with a man outside the marriage, or concubinage, the husband had intercourse with a woman outside the marriage. Sacrilegious children, if they were children born of ordained parents, so born to a nun or born to a priest. Incestuous children, children born from an incestuous relationship, so blood-related parents. Or mancerous children conceived by prostitutes. Okay, so that is what we mean by spurious children. Next question. A 21-year-old male reports that he has ulcerated bleeding lesions all over his body. He believes that he caught an incurable, highly infectious disease causing the lesions. On examination, however, his skin is clear. Further investigation reveals that the symptoms only started when his notice for a court summons arrived. He most likely has which condition? So our answer here is letter D, malingering. Ano yung buzzword natin dito is the symptoms only started when his notice for a court summons arrived. So he has a cause to malinger. So he wants to avoid jail time. He wants to avoid going to court. And so he started to make up symptoms in order to prevent having to face his responsibilities. Choice A, or illusions, is wrong. Remember, illusions is false interpretation of an existing external stimulus. So for example, if I look at this curtain next to me and I say, mukha siyang white lady, that's an illusion because there is an existing external stimulus, which is the presence of the curtain. And ako, I have a misconception of it. Choice B, or hallucinations, means there is no stimulus. I'm just looking at something blank, pero may mga nakikita ako. That is hallucinations. Choice C, or delusions, can also be considered if this patient had a a false belief that he believes to be true of having an incurable disease. So this is known as hypochondriacal delusion. So hypochondriac yung pasyente. However, in this case, because of the presence of a cause for malingering, the best answer is still letter D. So remember, it is feigning or simulation of a disease or injury characterized by exaggeration, inconsistency with physical exam, and ostentation. Okay? And it's really important to suspect it whenever there is a cause for the subject to malinger. So meron siyang iniiwasan, either makukulong siya or meron siyang kasalanan na gusto niyang iwasan. Then if those things are present, you would have to consider malingering. So there has to be inconsistency between the injuries or disease suffered from the symptoms or disability manifested. So ang symptoms niya daw ay may rash, pero in physical exam wala. So it is not supported with organic lesions. It was a very abrupt onset. And if the patient were to be subjected to annoying or painful treatment, they would tend to refuse it kasi alam naman nila that there's nothing there. Okay? So these are the disorders of perception. So you have illusions, which I've already explained, and hallucinations. Remember, they don't have to be auditory. They can be visual, olfactory, gustatory, tactile, kinesthetic. Hypnagogic, which is go to sleep. So it is a false sensory perception occurring midway between falling asleep and being awake. So ibig sabihin, as you're about to go to sleep, you get hypnagogic hallucination. So go to sleep, hypnagogic. Okay. And these are the different types of delusion. So I'll just highlight the hypochondriacal delusion, which is a false belief that one is suffering from an incurable disease, parts of their body are non-functioning, or that they are not physically capacitated to do a thing on account of the disease. So in terms of delusions, hindi sila nag-iimbento. They really actually believe that they have this condition. Next, which refers to the progressive fall of body temperature and is considered one of the most prominent signs of death. So our answer here is letter C, algor mortis. So remember, algor is Latin for cold. So algor mortis is the progressive fall of body temperature after death. So let's go through the different choices and bakit sila mali. So choice A, or Magnus test. So this is a test wherein a ligature is placed on a finger to check for color changes. So that is not the drop in body temperature. Choice B, or marbleization, is the prominence of superficial veins with reddish discoloration. So nagmumukhang marble pattern yung skin. Choice D, or Winslow test, is a bit funny for me. So you put a saucer with water on top of the patient's chest, and if my changes in the reflection of the light, that suggests that there is breathing or there is movement upward and downward of the chest. Okay, so signs of death, check. Has the heart stopped? So you can do that with the Magnus test, application of heat on skin, palpation of a pulse. Is there cessation of respiration? Is the patient still breathing? So you can put a mirror in front of their nose or their mouth, and if there is misting, that would suggest the patient is still breathing. Or the Winslow test, as I explained earlier. Or cooling of the body, which is one of the most prominent signs of death. So algor, again, is Latin for cold. So don't forget that algor mortis means progressive fall of the body temperature. So other signs of death include insensibility of the body and loss of power to move. So no stimulus can produce voluntary movement, no amount of pain, trapezius squeeze, supraorbital pressure, sternal rub, hindi talaga sila gumagalaw. That is another sign of death. Changes in the skin, so things like contact flattening. So in areas where the body is in contact with the surface, it loses elasticity, so it becomes very, very flat. And changes about the eye, so loss of a corneal reflex, clouding of the cornea, flaccidity of the eyeball, and the pupil is in position of rest. At 6 a.m., a body was found to be flaccid all over. No abdominal distension nor any discoloration were noted. What is the approximate time of death? 5 a.m. the same day, 1 a.m. the same day, 7 p.m. the previous day, or 4 a.m. the previous day. So it's asking how much time has elapsed. So this body is flaccid, walang distension, walang discoloration. So this suggests the death was very recent. And so our answer is letter A, 5 a.m. the same day. Okay. So what is the stage of decomposition that this body is in? It is in the stage of primary flaccidity. Ibig sabihin, your rigor mortis still has not set in. Your lividity or change in color has not set in, nor has there been any putrefactive changes causing abdominal distension or bloating. So 5 a.m. the same day, ibig sabihin only 1 hour has passed. Kung 1 a.m. the same day or 5 hours have 5 hours have already passed, at this point, you will already see some signs of rigidity and changes in color or lividity. Kung 7 p.m. the previous day, that would mean about 11 hours have passed. Definitely, rigidity and lividity would be nearing their peaks. Choice D, or 4 a.m. the previous day, so over 24 hours have passed, you would already see signs of decomposition like putrefactive changes. So you would find greenish discoloration and abdominal distension. So these are things that would point us towards a duration of death. Remember, before rigor mortis sets in, merong stage of primary flaccidity because rigor mortis tends to set in 3 to 6 hours after death. It is fully developed after 12 hours and then goes away after 24 hours. So the disappearance of this rigor mortis is concomitant with the onset of putrefaction. So ibig sabihin, the onset of decomposition occurs after the absence of rigor mortis at 24 hours, which is why at about 24 to 48 hours, that is when putrefaction occurs, especially in tropical countries. So postmortem lividity, the same as rigor mortis, onset 3 to 6 hours after death, and then peaks at about 12 hours. So these are the times since death, and these are the conditions of the body which you can find depending on how much time has elapsed between death and when you found the body. So kung 12 hours, remember, dapat present na yung rigor mortis all over. There would be hypostasis of the blood, well developed and fixed. And there would be greenish discoloration showing over the dependent part of the body, which would be about the cecum. Kung 24 hours, mawawala na yung rigor mortis and putrefaction would start to spread. So in addition to showing over the cecum, it would start to spread all over the whole abdomen and even go to the chest. And the abdomen would start to be distended with gases from the bacteria starting to eat your tissue. 48 hours or 2 days, meron ka ng ova of fly, sobrang bloated na ng trunk, abot na din sa face ang discoloration and swelling. There would be blisters present, and buzzword dito ang moving maggots seen. 72 hours, so the whole body is now grossly swollen and disfigured. Your hair and nails are loose and tissues are soft and discolored. So at 1 week, putrefied na entirely ang soft viscera. At 2 weeks, halos nawala na lahat ng soft tissues and only the more resistant viscera are distinguishable. The rest parang tubig na lang. And at 1 month, you would expect to see just the skeleton left. Next, which is allowed to be done by a physician appearing in media? Is it A, mentioning affiliation to an institution, B, discussing topics which are not under their field, C, endorsing brands of herbal supplements, or D, listing down personal achievements and awards? So according to our medical jurisprudence and ethics, the answer here is letter A. So the only things that a physician can mention when appearing in media is their name, their membership to a society, and their membership to an institution. So for example, I would only be allowed to say technically, hi everyone, my name is Dr. Gabriel Flores. I'm a member of the Phi Lambda Delta sorority and I am affiliated with the Philippine General Hospital. So technically, yun lang yung pwede kong sabihin. Choice B, which was discussing topics which are not under their field, definitely hindi pwede. So I'm a general practice trainee here in the UK. So obviously I can't start speaking about neurosurgery on media. Choice C, endorsing brands of herbal supplements. Definitely, physicians cannot commercially endorse any medical or herbal or health products. Choice D, listing down personal achievements and awards. So it's not that bad to do it, but it is not allowed since only these 3 things are allowed to be mentioned in media. Last question, medical paternalism goes against which ethical action? A, preventing harm from occurring to others. B, do not incapacitate or cause offense. C, obtaining consent for interventions, or D, upholding a triage system in a hospital. So medical paternalism goes against obtaining consent for intervention. So what is medical paternalism? It is the mental model that the doctor knows best. The doctor knows best and therefore there's no point in getting consent from the patients or giving informed consent kasi the doctor will do whatever the doctor thinks is best for you. So again, it is the doctor which determines that a patient's wish or choices should or should not be honored. Thus, in this scenario, consent is not necessary. So it goes against the principles of informed consent. Okay, so these are medical paternalism is a set of attitudes and practices wherein the physician determines that the patient's wishes or choices should not be honored kasi we think that we know best. So in the past, paternalism was considered an absolute medical necessity as there was little to no public understanding of medical procedures and practices. However, of course, in recent years, the public is more empowered, the public is more informed, and they shouldn't just be placing their blind faith in doctors' decisions. They should be given the opportunity to give us their informed consent. So there are different models. There's activity passivity, wherein the doctor treats the patient as one who cannot or should not make the decisions. So the physician is the active role and the patient is the passive role. In guidance and cooperations, the patient has feelings and aspirations and they do have their opinions, but since they are sick, they are willing to cooperate. So the physician guides and tells the patients what to do. The patient's role is to cooperate or to obey. In mutual participation, this is the ideal model. The physician admits that we are not infallible. We do not always know what's best. So the physician's role is to help the patient help themselves, and the patient's role is to be a partner here. Okay, and that's the end of your legal medicine, medical jurisprudence, and ethics finals.
Now, you're on the last subject for day 2, pathology. Okay, starting with number 101. A 65-year-old male had progressive dementia for the past 10 years, ultimately dying of pneumonia. Autopsy revealed narrowed gyri and widened sulci. What is the adaptation demonstrated in this case? It's known as atrophy. Eh, syempre, atrophy ka kasi lumiit ang iyong brain parenchyma, leading to narrowed gyri and widened sulci. Ang sulci, yan ang ating pagitan between your gyri. So mas lumawak siya, mas lumit kasi ang iyong brain parenchyma in the process. And true enough, your different neurodegenerative diseases have 2 major mechanisms leading to its presentation. One, you have accumulation of abnormal protein aggregates. And the other one is loss of neurons leading to brain atrophy. 102. Which of the following complement components is not involved in the mannose binding lectin pathway? The correct answer is A, C1. Now, your different pathways, all of them converge in the formation of a C3 convertase. Therefore, C3 is always involved across all of them. Pero ang kakaiba sa kanya, ang ating MBL, it only has C2 and C4. While C1 is only involved in the classical pathway. Kaya C1 ang tamang sagot in this question. 103. A 30-year-old male, 160 centimeter in height, presents with a knife-like anterior chest pain radiating to the back. After managing his problem, testing of genes was done, revealing a mutation in the gene coding for collagen. What is the most likely diagnosis? Now, ano ba ang presenting problem ni patient? A knife-like anterior chest pain radiating to the back. Most likely that is aortic dissection. Kaya having a knife-like chest pain going to the back. That is aortic dissection. So in this case, mukhang malabo ang ating C and D dito. Okay, kasi ang C, ano ba ang C? C is Goodpasture syndrome. Does not present with AD. It's a problem of the lungs and the kidney. While Alport syndrome, it is involved in having nephritic syndrome and also having ocular problems and sensory neural problems, leaving us with A and B. Both A and B, pwede kayo magkaroon ng acute aortic dissection. Pero ang sinabi sa ating tanong, there is a mutation involving the collagen. So ang tamang sagot dyan ay Ehlers-Danlos syndrome. Bakit? Kasi ang Marfan syndrome kasi ay defect in the fibrillin protein. Fibrillin is not a collagen fiber. It is the scaffold protein responsible for elastin synthesis. So A is the correct answer in this question. So guys, recall your Ehlers-Danlos syndromes. Marami siyang types. Okay? In our case, it is a type 4 EDS, also known as a vascular EDS. Okay, as mentioned kanina, Marfan syndrome, parehong-pareho, di ba? Except the question kasi, hindi kasi involved ang collagen in Marfan syndrome. Ang involved dyan, ang ating fibrillin protein. 104. A 15-year-old male presents with dyspnea and a new onset holosystolic murmur at the apex, radiating to the axilla. He contracted bacterial pharyngitis a month prior. What type of hypersensitivity does his current condition fall under? So, meron kang previous na bacterial pharyngitis at nagkaroon ka ng new onset na murmur. So, typical yan for those patients having rheumatic heart disease. Now, the question is, ano ba ang hypersensitivity type ni rheumatic heart disease? It is a type 2 hypersensitivity reaction. Now, may isa pang sequelae ang ating strep pyogenes infections. Kapag ang involved naman, usually ang skin, the skin may lead to acute post-streptococcal glomerulonephritis. And that type of sequela is a form of type 3 hypersensitivity reaction. So ano ba ang ating autoimmunity trigger for your acute rheumatic fever? It is your M protein. Kasi it is by your molecular mimicry. Ang M protein ng ating streptococcus kasi ay kamukha ng ating cardiac self-antigens. So nangyayari, yung antibodies natin ay tinitira ang ating cardiac self-antigens, leading to heart damage, leading to your rheumatic heart disease. 105. Which of the following cancers typically disseminates hematogenously? So, in this question, what if nakalimutan mo yung ating concept dito? You actually can perform here testmanship. Kung papansinin, B, C, and D are all what? They are all carcinomas, right? While A is an osteosarcoma. So, by testmanship, A is the correct answer here. But true enough, guys, always remember that lymphatic spread is seen in carcinomas, while hematogenous spread is seen in sarcomas. But take note that there are 4 carcinomas that root hematogenously. FCRH, follicular thyroid carcinoma, choriocarcinoma, RCCA, and hepatocellular carcinoma. Yung 4 na carcinoma na yan, they metastasize via the hematogenous pathway. 106. A 25-year-old female underwent routine pap smear. On speculum, she has moderate thin white vaginal discharge, and pap smear showed absence of lactobacilli and presence of a short gram-variable coccobacilli. What is the most likely diagnosis? So in this case, let's first check the gross morphology of the lesion. There's a thin white vaginal discharge. So kung yan ang isipin natin, baka malabo na si ating trichomonas. Kasi in trichomonas, usually meron siyang green-yellow na discharge. Pag candida, ang nakikita dyan ay usually cottage cheese curdy na discharge. So parang malabo na si candida. And true enough, pap smear showed the absence of lactobacilli. And lactobacilli, that is the predominant normal flora in the vaginal tract. Now, kapag nabawasan sila at namamang ang ating short gram variable coccobacilli, known as Gardnerella vaginalis, magkakaroon ka ng bacterial vaginosis. So guys, take note also of our Amsel criteria. Okay, we have thin, white-yellow, homogeneous discharge, the clue cells, which are epithelial cells which contain your Gardnerella vaginalis, and a vaginal fluid of more than 4.5. Trichomonas, guys. You also have your strawberry cervix. Ang candida having a thick, curdy discharge. Moreover, among the 3, candidiasis po ang merong pH of less than 4.5 because fungal organisms love acid. Pag-uusapan naman ay atrophic vaginitis, it usually occurs in postmenopausal women kasi nagkakaroon ka ng lack of estrogen at this state. 107. A 40-year-old girl delivered at home by a hilot, and she presents with bruising and bleeding from the umbilical stump. What is the most likely cause of bleeding? So, a bleeding and a baby. Okay, so mukha siyang problema siguro ng coagulopathy. Most likely kasi, ang baby ay na-deliver saan? Sa bahay lang. Kasi kapag nagawa yan sa institution, usually magkakaroon ka ng vitamin K supplementation. And take note that neonates are very prone to vitamin K deficiency. Bakit? 1, ang breast milk ay walang vitamin K. Pangalawa, vitamin K is a fat-soluble vitamin. While our neonates are mostly made up of water, it's 85% water ang mga babies bagong panganak. So, mahirap pa-store ang vitamin K sa katawan nila. And lastly, take note that vitamin K is mainly provided by our intestinal microflora. Ang ating mga neonates hindi pa develop ang kanilang microflora kasi hindi pa sila kumakain ng food. Okay? Hindi pa sila exposed masyado sa bacteria outside. Therefore, they have a higher risk for having vitamin K deficiency problems. And take note that vitamin K deficiency can lead to problems in your 1972. Factors 10, 9, 7, and 2, leading to prolongation of your PT and PTT. 108. Which vitamin is expected to be deficient in a patient with cystic fibrosis? Okay guys, ito naman to. Pag di mo alam masagot guys, always use testmanship. You find the odd man out here. Vitamins B1, C, and B2 are all water-soluble vitamins. Therefore, di lang dyan ang ating fat-soluble vitamin. And it is the correct answer. Because those patients with cystic fibrosis, they can also have exocrine pancreatic insufficiency. Meaning wala silang enough na nilalabas na lipase. Lipase which is important for the dissolution of fatty molecules. If wala kang lipase, hindi mo masira ang fat. Therefore, the fat will be not absorbed by the small intestines. Therefore, nagkakaroon ka ng fat malabsorption. If you have fat malabsorption, hindi mo rin ma-absorb ang ating mga fat-soluble vitamins, namely your addict vitamins. Vitamins A, D, E, and K. 109. A patient presents with an adrenal tumor with intractable or resistant hypertension. Serum potassium is low. Which of the following best explains the patient's hypertension? Best answer here is increase intravascular volume. This is a case of what we call hyperaldosteronism. Ano bang function ni aldosterone? If you have high aldosterone, what happens? Sodium is returned to the blood while potassium is lost in the urine. Kaya ka merong hypokalemia. Pero dahil ang sodium mo ay nare-retain sa katawan mo, you will have hypernatremia. Take note that water always follows sodium. Therefore, if you have high sodium in the blood, magkakaroon ka ng water retention. And that water retention will lead to an increase in intravascular volume, leading to a higher blood pressure. Okay? So B is the correct answer here. Now, ang A natin, that pathology is involved where? It's involved in the Cushing syndrome. Because in Cushing syndrome, we have your high levels of glucocorticoids. And high level of this hormone will lead to an increased sensitivity to pressors, leading to a higher blood pressure. Now for C naman, increased catecholamine levels, it is involved in your pheochromocytoma, a tumor of your adrenal medulla. Take note guys, iba, ang medulla releases 80% epinephrine and 20% norepinephrine. And those hormones will increase your blood pressure. 110. This type of Kaposi sarcoma is typically seen in older men of Mediterranean descent and has an indolent clinical course. Ito, must know concept yan. You have to know this. Okay? So, among them, ang tamang sagot dyan ay classic Kaposi sarcoma. A, B, and C, walang involvement dyan ng HIV. But the epidemic Kaposi sarcoma, that is the one involved in HIV disease. Okay, so take note guys ha, ang classic na KS, older men, Mediterranean, and as an indolent course. Pag endemic African KS, again, wala siyang HIV infection association, but it can have an aggressive course, severe form in pre-pubertal children. In transplant-associated KS is involved kapag nagkaroon ka ng solid organ transplant receiving T-cell immunosuppression. But then again, guys, always remember, epidemic KS is the one seen in AIDS-defining illnesses. 111. Which component of TOF primarily determines the degree of shunting? Ano ba ang ating TOF? Okay, it's a cyanotic heart disease. Meaning you have a right to left shunting. So among the following, your right ventricular outflow tract obstruction is the one that determines the degree of your right to left shunting. So bakit ba ganun ang nangyayari? Kasi if you have a high obstruction in the right ventricular outflow tract, nangyayari, tumataas ang ating RV pressure. That increase in RV pressure will definitely lead to right ventricular hypertrophy. Pero more than that, that pressure will cause a backflow. So nagkaka-backflow dyan, at dahil nagkaka-backflow dyan dito, tumataas ang ating right to left shunting dito. Okay? Tumataas ang ating right to left shunting sa ating VSD level. Okay? And that will determine your degree of cyanosis as well. 112. An 80-year-old African male presents with a rapidly enlarging mandibular mass. Biopsy showed a starry sky pattern, okay, with sheets of atypical round cells with scattered tingible body macrophages. Which of the following genetic abnormalities is characteristic of this lesion? Guys, buzzword, starry sky pattern, always think of Burkitt lymphoma. And Burkitt lymphoma presents if you have a problem of the translocation of 8 and 14 chromosome. Okay, guys, take note of that concept. That will lead to MYC overexpression. Kapag translocation involving 15 and 17, that is your acute promyelocytic leukemia. Pag 14 and 18, that is your follicular lymphoma. Kapag 9 and 22, that is your Philadelphia chromosome seen in chronic myeloid leukemia. 113. Which of the following laboratory findings is seen only in anemia of chronic inflammation? Correct answer is high ferritin. Bakit? Kasi if you have IDA, expected na mababa ang iyong serum iron. Tama, right? And dapat mataas ang iyong TIBC. Kasi TIBC, ang point niyan ay pag mataas siya, konti ang saturation ng ating transferrin. Meaning, konti ang iron na makikita sa ating transferrin. Now, ultimately, sure ka na meron kang high ferritin in anemia from inflammation. Kasi you have what we call hepcidin. Ang ating hepcidin is the chief regulator of iron in the body. Okay? So, ano ba ginagawa niya? It basically blocks off the release of iron from our macrophage storage system and also prevents absorption of iron from the duodenal enterocytes going to the blood. Therefore, tumataas ang levels of stored iron in the body. And take note that ferritin reflects stored iron in the body. Kaya tumataas ang ating ferritin in states of anemia of chronic inflammation. It is the best answer in our case. Bakit, Doc, hindi B? Kasi minsan kasi guys, in early phase of IDA, meron ka pang normal serum iron levels. So, hindi siya very reflective of anemia from inflammation. Kasi it can also be seen in early IDA. So, A is the best answer here. 114. A 75-year-old male was admitted in the ICU for sepsis presenting with dyspnea and worsening of hypoxemia despite aggressive ventilatory support, and eventually the patient died. Which of the following findings is expected in the lungs of the patient? So a septic patient na mukhang nagkaroon ng ARDS. In ARDS, acute respiratory distress syndrome, ang pathology sa lungs ay hyaline membranes. Ang ating honeycomb fibrosis, it's seen in your end-stage chronic interstitial lung disease. Thick, tenacious mucus plugs seen in status asthmaticus, while diffuse pulmonary hemorrhage can be seen in lung vasculitis syndromes. 115. Which of the following features is typical of Crohn's disease? Okay, it's a form of non-caseating granuloma. Okay, that is actually seen as a transmural form of inflammation. Tumatagos talaga siya across the GI wall. Dahil tumatagos siya, prone ka for having sinuses, prone ka for having fistulas in the process. Okay? Take note the differentiation of your Crohn's disease and ulcerative colitis. Ano pa mga important dyan, guys? Take note of their location. Ang colitis is mainly colon. Okay? Ang involvement dyan. Pag Crohn's, any part of the GI tract. Distribution, Crohn's eye skip lesions, diffuse ang lesions ng ating ulcerative colitis. You also need to know their risk factors. Risk factor for CD is smoking. Pero, studies say that smoking may relieve symptoms for ulcerative colitis. Moreover, appendectomy is a protective factor for ulcerative colitis, but it may cause progression of symptoms in Crohn's disease. Take note of these concepts. 116. A 35-year-old male with post-streptococcal acute glomerulonephritis presents with oliguria and azotemia. Now, a biopsy was done showing crescents compressing the glomerular tuft. What is the most likely diagnosis? If you see crescents, always think of a rapidly progressive glomerulonephritis. However, may mga types pa yan depending on the etiology of RPGN. In this case, okay, it's a PSGN ang kanyang etiology. Type 2 yan because type 2 is about immune complex mediated injuries. Okay, so take note of this concept. Pag mga anti-GBM antibodies, usually, yan yung mga good posture syndrome natin. Pag ANCA, involved dyan ang ating mga different na kidney problems, like mga Wegener, for example. 117. A 6-year-old girl presents with bloody vaginal discharge, bilateral breast enlargement, and an ovarian mass. What is the most likely diagnosis? So in this case, okay, pre-puberty na pasyente, meron ng discharge, di ba? Meron na siyang secondary sexual characteristics. So think of a disease na naglalabas ng hormones ng pangbabae that can cause secondary sex characteristic changes. Think here of your estrogen and progesterone coming from B. granulosa cell tumor. Kasi this cell tumor releases estrogen and progesterone in the process. Ang ating mga teratoma, they are not involved in hormone secretion. Rather, ang ating teratoma is involved in ovarian torsion. Okay? So think of these diseases. Now, ano pa? Pag ang usapan naman ay fibroma. Kung fibroma ang usapan, think of your Meigs syndrome. Your Meigs syndrome has ovarian fibroma, ascites, and pleural effusion. Yan ang mga testable concepts about ovarian tumors. 118. Which profile of the breast mass is amenable to trastuzumab therapy? Correct answer, the one with HER2 positivity. Kasi HER2 positivity, yan ang target ng ating trastuzumab. Okay? So, it is the target of our monoclonal antibody, trastuzumab. Doc, do we need to know the molecular subtypes? Nice to know lang yan. Akala mong malaman ang implications ng ating ER positivity, PR positivity, and HER2 positivity. Now, ano ang kagandahan ng ating ER tsaka PR positivity? If positive ka dyan, you may perform hormonal therapy for your breast cancer patient. 119. A 30-year-old female presents with proptosis, weight loss, and heat intolerance. Which of the following thyroid function test findings is consistent with her presentation? Now, weight loss and heat intolerance are features of your hyperthyroidism. Now, in this case, meron kang proptosis. So, mukhang hindi lang siya hyperthyroidism. Mukha siyang Graves' disease. But regardless, if we have hyperthyroidism state, dapat mataas ang iyong T3. Kasi it's a form of primary hyperthyroidism in this case. If Graves siya, we call that Graves' disease is a problem of the thyroid gland. Therefore, mataas ang ating T3 in the process. And via negative feedback, mababa ang ating TSH. Okay? So this is a presumptive case of Graves' disease. Having hyperthyroidism and having ophthalmo problem. Okay? 120. A 55-year-old female presents with a progressive headache. In the imaging, may nakita kang extra-axial dural base mass. And meron siyang samoma bodies upon biopsy. What is the most likely diagnosis? Ang sabi ay extra-axial. Therefore, hindi siya part ng ating CNS. So the mass is found outside the CNS, outside the brain, and outside the spinal cord in terms of origin. And it is confirmed by being a dural base mass. So based on that description alone, alam mo na mukha siyang meningioma stemming from the dura mater. And dura mater is a form of or a layer of the meninges, di ba? And on top of it, may nakita kang samoma bodies. And take note that meningioma has samoma bodies. They also have monomorphic bland epithelioid cells. Okay? So take note of the morphology of different gliomas. Now, ang aking pearl dyan is yung ating samoma bodies. You have to know that concept. Kasi samoma bodies, okay, yung A lang ang hindi kasama dyan ha. P is for papillary cancers, thyroid, and renal. S is for somatostatinoma. MM is for malignant mesothelioma and also for malignant or invasive meningioma. O is for ovarian serous cystadenoma and M, milk, is for prolactinoma.
Okay, next, let's go into your finals questions for pharmacology. First question, in which patient group would hydralazine be contraindicated? A patient with severe hypertension, B, heart failure patient when given with nitrates, C, a hypertensive patient with established PAD, or D, a pregnant woman with eclampsia. Our answer here is letter C, so contraindicated in patients with established coronary artery disease. So remember, hydralazine is one of the first antihypertensives ever discovered, but it is no longer first line because it has such a high adverse effect profile. So its mechanism of action is via altering your intracellular calcium metabolism. It vasodilates mostly your arterioles. Therefore, its effect is greatest on the decreasing of your afterload. So it is used in preeclampsia, in severe hypertension, and when given with nitrates, it is used in heart failure. So therefore, choice A, choice B, and choice D are indications to give hydralazine, not contraindications. The side effects include severe psychiatric depression, suicidal ideation, drug-induced lupus, and myocardial ischemia. So how does it do that? So hydralazine, because of how potent it is as a vasodilator, it vasodilates your arterioles, and because it does this so well, your blood pressure drops very quickly. And your baroreceptors, which detect drops in blood pressure, would then initiate a powerful stimulation of your sympathetic nervous system as a compensatory response. So your sympathetic system goes haywire, you get tachycardia, increased contractility, increased renin activity, and fluid retention, all of which will increase your oxygen demand of your myocardium. Therefore, if you have a pre-existing coronary artery disease where there is already an obstruction to delivery of oxygen to your cardiac tissue, you can precipitate frank MI. So therefore, the uses have been limited to, again, choice A, severe hypertension, choice B, congestive heart failure if given with nitrates, kasi like I said, arterioles are the ones that are vasodilated by hydralazine, so may reduction of afterload. Nitrates naman vasodilate your venous system, so there is reduction of both preload and afterload if you give nitrates and hydralazine together. So if you mix them, they have been shown to improve mortality in patients with HF. And lastly, hypertensive emergencies in pregnant patients, so things like eclampsia or preeclampsia. They should not be used in elderly patients because it can cause quite severe hypotension, and again in hypertensive patients with coronary artery disease, or choice C. Next, a patient with a ventricular arrhythmia was given a drug, after which they developed a headache, vertigo, and tinnitus. Which drug was most likely given? Is it lidocaine, procainamide, mexiletine, or quinidine? Our answer here is Letter D, quinidine. What is this? Headache, vertigo, and tinnitus. That is, of course, your synchronism, which is a side effect of your quinidine. Ano yung side effect associated with choice A or lidocaine? This is a local anesthetic. So if you give it intravenously as an antiarrhythmic, you can precipitate a seizure as part of your last or local anesthetic systemic toxicity. Procainamide is implicated in lupus-like syndrome, whereas mexiletine doesn't really have a special side effect associated with it. Quick review of antiarrhythmics. Remember na bakla ka. So class 1 is NA channel blocker, class 2 beta blocker, class 3 potassium or K channel blocker, and class 4 is calcium channel blocker. Class 1, pinahirapan pa tayo ng pharmacology, but it subdivided it into 1A, 1B, 1C. So remember, so 1A, double quarter pounder. So your disopyramide, quinidine, and your procainamide. 1A, akyat, it prolongs the action potential. See 1B, pengeng lettuce mayo tomato with your double quarter pounder. Phenytoin, lidocaine, mexiletine, and tocainide. 1B for baba, it shortens your action potential. And 1C plus fries, propafenone, and flecainide. C for constant, so wala siyang effect on your action potential. Next, which of the following drugs causes depolarizing neuromuscular blockade in helminths? Is it A, diethylcarbamazine, B, pyrantel pamoate, C, ivermectin, or D, albendazole? Our answer here is letter B, pyrantel pamoate. So quick review for anti-helminthic drugs. Yung mga bendazoles mo, albendazole, mebendazole, they work by inhibiting polymerization of your microtubules by binding to beta-tubulin. So drug of choice siya for most of your roundworms or your nematodes. If you see a nematode and hindi ka sure kung anong drug of choice, if may albendazole or mebendazole sa choice, sa options, just pick that. Yun yung most likely answer. Diethylcarbamazine, the mechanism of action is not fully known yet, but it is a drug of choice for filariasis, your Wuchereria, and your Brugia, and your Loa. Ivermectin, it works by inducing tonic paralysis by activating your chloride channels. So this is the drug of choice for your strongyloides. Praziquantel causes spastic paralysis and is the drug of choice for most trematodes and cestodes. Buzzword, if may nakita kang schistosomiasis, look for praziquantel in the options. And pyrantel pamoate, which was the answer previously, causes depolarizing neuromuscular blockade and is used as an alternative to your bendazoles in the treatment of nematode infections. Which of the following patients cannot be placed on a beta blocker? Is it A, a post-MI patient, B, a patient with chest pain, C, a patient with AFib, or D, a patient with a third-degree atrioventricular block? Our answer here is letter D, patient with third-degree AV block. Bakit? Remember, in an AV block, there is complete dissociation between your atria and your ventricles. So if you give this patient a beta blocker, you will simply worsen the heart block and you can cause a life-threatening bradyarrhythmia. So wala nang communication between your atria and your ventricles. Binigyan mo pa ng beta blocker, which would slow down the AV node even more. You would just worsen their existing condition. Choice A, your post-MI patient, remember that's not a contraindication. In fact, beta blockers have been shown to improve mortality in patients who have had an MI in the past. So maintenance medication na ang mga nagka-MI in the past, ang beta blockers. Choice B, your patient with chest pain. So again, this is not a contraindication, but is in fact an indication. So we give beta blockers as first line in treating patients with stable coronary artery disease. Choice C is also not a contraindication, so AFib. In fact, we give these patients propranolol as one of the first-line drugs given to control the rate in atrial fibrillation. So olol, remember, are your beta blockers. So remember, how do beta blockers work with the heart and how do they treat angina, etc.? Remember that we want a balance between oxygen demand and oxygen supply. Whenever demand exceeds supply, you get ischemia, usually manifesting as chest pain or in very severe cases, MI. So by lowering the heart rate and lowering the contractility via the use of your beta blockers, you can lower the O2 demand and therefore you can help with things like ischemic chest pain, stable angina, etc. So what are the absolute contraindications to beta blockers? Number 1 is severe or symptomatic bradycardia, because obviously you will just worsen this bradycardia. Third-degree heart block, some references also say second-degree heart block is a contraindication. So basta may heart block, be wary to use beta blockers. Acute decompensated heart failure and cardiogenic shock. So very important to note, acute. So hindi chronic heart failure. Acute decompensated heart failure, remember what happens is your heart is no longer pumping properly. Beta blockers decrease contractility of the heart. So in a heart that is already acutely decompensating, if you reduce the contractility, the patient will die, or you will push the patient into cardiogenic shock. However, in a patient who has chronic stable heart failure, beta blockers reduce mortality and is standard of care. Pheochromocytoma if you don't give a concomitant alpha blocker, and severe hypotension. Next, which drug is incorrectly matched to its site of action? Is it A, chlorthalidone, B, bumetanide, chlorthalidone to the thin limb of the loop of Henle, B, bumetanide, loop of Henle, C, acetazolamide, proximal convoluted tubule, or D, amiloride collecting ducts? Our answer here is letter A, chlorthalidone. Chlorthalidone is one of your thiazide-like diuretics. Therefore, the site of action should be distal convoluted tubule. The rest of the options are correct. Bumetanide is one of your loop diuretics. Acetazolamide is your carbonic anhydrase inhibitor acting in the proximal convoluted tubule. And amiloride is one of your potassium-sparing diuretics. So don't forget the diuretic site of actions. Your mannitol acts as an osmotic diuretic, so it acts within the lumen of your tubules. Your zolamides, your acetazolamide, torzolamide, is a carbonic anhydrase inhibitor in the proximal convoluted tubule, itong in pink here. Loop diuretics, as the name suggests, like your furosemide and your bumetanide, these are your NKCC or sodium potassium 2 chloride inhibitors found in the thick ascending limb of the loop of Henle. Then as we go more distal, in the distal convoluted tubule, you have your thiazide and your thiazide-like diuretics, like your hydrochlorothiazide, indapamide, and your chlorthalidone. So these act in the distal convoluted tubule. And lastly, in your collecting ducts, you have your potassium-sparing drugs, like your aldosterone inhibitors like spironolactone, or your NAC inhibitors like your amiloride or triamterene. So these are in the collecting ducts. Next, which of the following drugs work by directly inhibiting factor 10A? So directly ang ating keyword here. Warfarin, bivalirudin, enoxaparin, or apixaban. Our answer here is apixaban, letter D. So remember, warfarin is a vitamin K epoxide reductase inhibitor. It inhibits or it interferes with the function of your vitamin K dependent coagulation factors, which are 10, 9, 7, and 2, 1972. Bivalirudin is a direct thrombin inhibitor, not factor 10A. Enoxaparin, yes, it inhibits factor 10A, but it does so indirectly. It does so by activating antithrombin 3. Apixaban, it bans 10A. Apixaban bans 10A. So nasa name na XA ban. You are banned XA because it directly inhibits factor 10A. So quick summary of your anticoagulants. Remember your heparins, they don't actually have any direct anticoagulant property. Instead, they activate antithrombin 3, which is an endogenous molecule. So by activating antithrombin 3, they indirectly inhibit thrombin and factor 10A. So in terms of decreasing size, you have the largest one, which is your unfractionated heparin. Again, anong side effect dito? It's your HIT, heparin-induced thrombocytopenia. So in response to the heparin-induced thrombocytopenia, they made a substance that is smaller, your low molecular weight heparin. Pero heparin pa rin siya, kaya enoxaparin, dalteparin. So even if they also function by activating antithrombin 3, they are more specific to 10A over thrombin inhibition. Versus your fondaparinux, so may parin pa rin, it indirectly acts exclusively on 10A. So wala siyang activity against thrombin. Your warfarin, again, vitamin K epoxide reductase inhibitor. It prolongs PT, remember PUET. So PT is prolonged by your warfarin, and therefore the effect is on the extrinsic pathway. Direct thrombin inhibitors bind directly to thrombin's active site, so they can be rudins or they can be gators. Bivalirudin, desirudin. Gators are gatroban, dabigatran. And your direct factor 10A inhibitor. So I am banning 10A. Rivaroxaban, apixaban, edoxaban. You are directly banning 10A. Okay? Which step of catecholamine synthesis does the drug reserpine inhibit? Is it synthesis, storage, release, or termination? Our answer here is storage. What blocks synthesis? It is your metyrosine. What blocks release? It is your guanethidine. What promotes release is your amphetamines and your tyramine. Termination, what blocks termination is your cocaine. And in cases of inhibiting degradation of your catecholamines, that's your MAO-Ice and your COMT inhibitors. So remember the catecholamine synthesis and release steps. Kapag reserpine yung tinatanong, it inhibits VMAT to block uptake and storage of amines into your secretory vesicles. Okay. Next question. Which drug used for genital warts works by upregulating cytokines and the immune response? Is it podophylox, tacrolimus, imiquimod, or carmustine? Our answer here is letter C, imiquimod. So lumabas na to in the previous board, so please remember this drug. Tacrolimus does not upregulate the immune response. In fact, it is an immunosuppressant. It inhibits T lymphocyte activation and prevents release of your inflammatory cytokines. Imiquimod naman, it stimulates white blood cells to release pro-inflammatory cytokines like TNF-alpha, IL-1, IL-6, and IL-8. So it is used as a topical cream, which you can use for your genital and perianal warts, actinic keratosis, which if you remember is a precursor lesion for your squamous cell carcinoma on the face and on the scalp, and your basal cell carcinomas as well. Next question. You are filling out a prescription for Sully and note that she is taking lamivudine. Which of the following conditions is or are she probably being treated for? Influenza A, hepatitis B, HIV, or B and C, Hep B and HIV? Our answer here is letter D. So both B and C. So hepatitis B and HIV. So sino nga ba si lamivudine? Remember, it is one of your nucleoside reverse transcriptase inhibitors. So it is an analog of cytosine, which has activity against both HIV, and hepatitis B. So usually, mas kilala siya for hepatitis B. However, in the recent boards, ang natanong ay lamivudine for HIV. So yes, pwede for HIV and Hep B. In fact, lamivudine is one of the recommended NRTIs for use in HIV-positive pregnant women. So please keep that in mind. Next, Shelley was found to have the BRCA gene after testing. She was placed prophylactically on raloxifene. Which of the following side effects should she be warned of? Is it A, endometrial hyperplasia, B, reduced bone mineral density, C, ovarian hyperstimulation, or D, deep vein thrombosis? So ang sagot natin dito ay letter D, deep vein thrombosis. So sino nga ba ulit si raloxifene? Remember, it is one of your SERMs, your selective estrogen receptor modulators. So yung dalawang pinakakilala are your tamoxifen and your raloxifene, specifically in the treatment of breast cancer. So they are agonists at some estrogen receptors, pero antagonists at other estrogen receptors. So si raloxifene, it is an agonist in the liver and in the bone. So si choice B, which was reduced bone mineral density, is incorrect because actually raloxifene is protective of your bone mineral density. Si choice A, which was endometrial hyperplasia, is also incorrect kasi actually antagonist si raloxifene sa uterus. Sino yung agonist sa uterus? It is your tamoxifen. So because it is an estrogen receptor agonist in the uterus, if you take tamoxifen, you have an increased risk of endometrial hyperplasia and cancer. So they are, of course, both antagonists in the breast tissue and in the central nervous system. See, ovarian hyperstimulation, which was choice C, we don't see that in either of these SERMs, but we do see it in your reproductive drugs like your clomiphene citrate. Now, deep vein thrombosis, both tamoxifen and raloxifene are associated with an increase in VTEs or venous thromboembolic events. So this includes your DVT and your pulmonary embolus. So both tamoxifen and raloxifene are associated with it. Next, your grandmother Nora has been diagnosed with acute angle closure glaucoma. Which of the following drugs should not be used? Is it A, scopolamine, B, physostigmine, C, brimonidine, or D, timolol? Our answer here is letter A, scopolamine. So sino nga ba si scopolamine? So scopolamine is another name for hyoscine or devil's breath. Hyoscine is a muscarinic antagonist, so therefore anticholinergic siya. So remember, kapag anticholinergic, will you get mydriasis or meiosis? You would get mydriasis, one of your Alice in Wonderland symptoms. So mydriasis or widening of the pupil can actually close the angle in acute angle glaucoma even more, and therefore it can precipitate another attack in patients who are anatomically susceptible. So that is why we actually advise patients with acute angle closure glaucoma not to go to dark theaters, because obviously in response to the dark surroundings, their pupils would dilate and that can precipitate an attack. So we have to remember the glaucoma drugs. So there are two ways by which we can treat glaucoma. Remember, ano nga ba yung glaucoma? It is an increase in intraocular pressure causing damage on the optic nerve. So we can either increase the flow of aqueous humor outside of the eye para mabawasan yung pressure, or we can decrease the production of the aqueous humor. So a way to remember it is CPAs increase cash flow. If you have an accountant, you have increased cash flow. So CPAs increase outflow of aqueous humor. Sino si C? Cholinomimetics, so cholinergic drugs like your pilocarpine. P for prostaglandin analog, so your latanoprost, brimatoprost, so prostaglandin. And your non-selective alpha agonists like your epinephrine as well. You can also decrease aqueous humor production by giving a CA inhibitor like your acetazolamide, which is a diuretic, a beta blocker like timolol, an alpha-2 agonist like brimonidine, or an osmotic agent like mannitol. Next, which of the following is an indication to prescribe danazol? Is it A, acne, B, endometriosis, C, hirsutism, or D, hepatic disease? Our answer here is letter B, endometriosis. So endometriosis is an indication, whereas A, C, and D are side effects in prescribing danazol. So sino nga ulit si danazol? It is a partial agonist of progestin and androgen. So you can think of it like a synthetic androgen. What does it do? So look at the figure on the right. This is your hypothalamus, this is your pituitary gland, and this is your ovary. What the danazol does is it acts as a negative feedback to the anterior pituitary so that we can inhibit the release of LH and FSH. So by inhibiting LH and FSH, this is an anti-gonadotropin agent. So therefore, its major use is in the treatment of endometriosis. So remember, in endometriosis, you get cyclical pelvic pain in response to uterine tissue found elsewhere in the body. So endometriosis, there could be uterine tissue deeply entrenched in your uterus. There could be uterine tissue in your ovaries. There could be uterine tissue in your bowels. And because these uterine tissues have estrogen and progesterone receptors, whenever you undergo your cycle of hormone fluctuations, you will experience pain and symptoms. So by inhibiting FSH and LH and stabilizing your hormones, you are treating the pain in endometriosis. It has also been used in fibrocystic disease of the breast, hemophilia, ITP, and angioedema. So choice A, which is acne, is a known side effect of any synthetic androgen. Choice C, which is hirsutism or hairiness of the face and the body, that is what we call virilization of women, which is a known side effect of synthetic androgens. Again, facial and body hair. Choice D, which is hepatic disease, is also another side effect because danazol in high doses can cause hepatotoxicity. Next question. Jack develops postpartum hemorrhage. She is given ergonavine by an obstetrician. What receptor does this drug act on that explains its uterotonic effects? H2, B3, 5-HT2, or 5-HT4D? So this is one of your ergot alkaloids, and your answer here is letter C, 5-HT2. So your ergotamine and ergonavine are all ergot alkaloids, ergo. They all have partial agonist activity at your 5-HT2 receptors, which causes strong vasoconstriction and strong stimulant action on your uterine smooth muscle, with ergonavine being more selective for the uterus. So if we can see this table from Katsung, the ergonavine has plus activity on the serotonin receptor and plus activity on uterine smooth muscle stimulation. Okay. Next, denosumab is used to treat osteoporosis. It works as a monoclonal antibody with blank as its target. Is it osteoprotegerin, IL-6, rank L, or PCSK9? Our answer here is, of course, letter C, rank L. So denosumab, so whenever a drug ends in mab, remember it means monoclonal antibody. So what does denosumab do? It is an antibody that binds to rank L or rank ligand to prevent it from binding to the rank receptor and stimulating osteoclast differentiation and function. Remember, your osteoclasts eat bone. However, your osteoclasts aren't always active and mature. They start as osteoclast precursors. Your osteoclast precursors have rank receptors, itong orange receptors here. And then you have rank ligands, these yellow things over here. When the rank ligand binds to your rank receptor, it causes activation and maturation of your osteoclasts. So your osteoclasts can continue to eat at the bone, therefore worsening osteoporosis. By inhibiting this step, so you can see denosumab is this blue monoclonal antibody here, you inhibit the activation of the osteoclasts as well. Now, choice A or osteoprotegerine is incorrect. So this does not target OPG. OPG is an endogenously produced decoy receptor. So OPG also prevents differentiation of osteoclast precursors to mature osteoclasts. So denosumab does not act on this. Choice B or IL-6. Ano ba yung monoclonal antibody that targets IL-6? Diba? It's your TOS6, tocilizumab. Choice D or PCSK9, is that associated with osteoporosis? No, diba? The PCSK9 inhibitor we know is evolocumab, and it is used in the treatment of hyperlipidemia, not in the treatment of osteoporosis. Ats is receiving treatment for pulmonary tuberculosis. He develops pins and needle sensations in his fingertips and toes. What drugs should have been co-administered with his medications to prevent this? Is it leucovorin, mesna, vitamin B6, or vitamin B12? Our answer here is vitamin B6. So Ats is receiving pulmonary TB treatment, meaning he's getting isoniazid, rifampicin, pyrazinamide, and ethambutol. If he has pins and needle sensations in his fingertips and toes, what is he experiencing? He is experiencing your peripheral neuropathy. And which anti-TB drug is associated with peripheral neuropathy? Diba? It's your isoniazid. So which is why we tend to give isoniazid with your pyridoxine to prevent neuropathy. Si leucovorin, that is what we give with your methotrexate, which is a folate antagonist. Si mesna is what we give as a treatment or as a rescue agent for cyclophosphamide-induced hemorrhagic cystitis. And si vitamin B12, it's something that we give for patients with malabsorption or with pernicious anemia. Next, Central C was prescribed conivaptan by Dr. Dre. What condition does Central C most likely have? Central DI, hemophilia A, SIADH, or bedwetting? So our answer here is letter C, SIADH. So conivaptan, remember, conivaptan is an ADH antagonist. So ibibigay natin siya when you have too much ADH. In central DI, you have too little ADH. So if you give conivaptan, you would worsen your condition. In bedwetting, again, ihi ka na nga ng ihi. So you need ADH. You need an antidiuretic hormone. So giving conivaptan would only worsen your condition. So remember, let's differentiate DI versus SIADH and the drugs used to treat them. DI is diabetes insipidus. So ihi ka ng ihi because your ADH or antidiuretic hormone is low. Therefore, your water retention is decreased. In syndrome of inappropriate ADH secretion, your ADH is very high. Therefore, you are retaining water rather than peeing it out. So you have too much ADH and you have too little. Now, what are the causes of DI? It can be nephrogenic. So lithium is one of the most implicated drugs in nephrogenic DI. What happens is meron ka namang ADH but your kidneys are insensitive to it. Sa central DI, your pituitary gland is not producing it in trauma, surgery, or tumors, versus the causes in SIADH, which can be trauma, surgery, tumors, or infections. So treatment, kung nephrogenic yung diabetes insipidus, meaning insensitivity of the kidney to ADH, you paradoxically give thiazide diuretics. Kung neurogenic, meaning central yung issue, so wala ka talagang ADH na pinoproduce, and then you have to get synthetic ADH or an ADH agonist. So this is your vasopressin or your desmopressin. So your pressins. Kung masyadong mataas ang ADH, edi you give an antagonist or something to lower that ADH. And these are your vaptans, conivaptan and tolvaptan. Okay, so the answer in the previous question would be SIADH. Kasi vaptan yung binigay natin, we are giving an ADH antagonist. Next, Mark G is a 90-year-old researcher who was diagnosed with Alzheimer's disease. He was then prescribed with donepezil and memantine. What receptor does memantine act on? Is it your dopamine 2 receptor, ACH receptor, NMDA receptor, or your cholinesterase? So our answer here is letter C, NMDA. So memantine acts on the NMDA receptor, particularly as an NMDA antagonist. So yung dopamine antagonist mo, think of your antipsychotic drugs like your haloperidol. Acetylcholine, so think of your cholinergic or your anticholinergic drugs in acetylcholine. Tapos yung cholinesterase mo, think of your indirect cholinergic drugs, your cholinesterase inhibitors, like your donepezil, rivastigmine, and galantamine, which are used in Alzheimer's disease. However, ang tanong dito was, what does memantine act on? So natanong in the previous boards, wag malito. Yes, we use donepezil, rivastigmine, and galantamine in Alzheimer's disease. They are first line and they act as inhibitors of your acetylcholinesterase. Remember, cholinesterases decrease the amount of ACH available in the brain, and they think that by increasing cholinergic activity in the brain, you can reduce some of the cognitive symptoms in Alzheimer's dementia. Si memantine, however, even if it is an Alzheimer's drug, its mechanism of action is different. It antagonizes NMDA, which is a glutamate receptor, and it is said to prevent neuroexcitotoxicity. So it is used as an adjunct for more advanced cases of Alzheimer's, particularly with your galantamine. So what are the drugs used for Alzheimer's? Si Doña Riva, may dementia, paggala-gala, at sobrang mema. Donepezil, rivastigmine, galantamine, and memantine. So remember na sa dulo si mema kasi hindi siya ACHE inhibitor. Instead, it is a NMDA antagonist. Next, which anti-diabetes drug carries an increased risk of vaginal candidiasis? Is it A, canagliflozin, B, linagliptin, C, exenatide, or D, metformin? Our answer here is your SGLT2 inhibitor, which is canagliflozin. So let's remember ano ba yung mechanisms of actions ng ibang drugs. Linagliptin, gliptin. Remember, this is your DPP4 inhibitor. Si exenatide is your GLP-1 agonist, basta it ends in tide. Si metformin is one of your biguanides, which is a sensitizer. So let's just quickly review the side effects of your diabetes drugs. Remember your sensitizers, it can be either biguanides or your TZDs. Your TZDs end in glitazone. Yung metformin mo, ang most common toxicity is GI disturbances, so diarrhea, nausea, and vomiting. However, the more severe side effect is lactic acidosis, especially in a patient with pre-existing hepatic or renal impairment. Yung mga glitazones mo like rosiglitazone or pioglitazone, the way I remember it is all that glitters is not gold kasi madami silang side effects. They cause fluid retention. If you're retaining fluid, you get edema, you get weight gain, and in somebody with congestive heart failure, you get worsening of heart failure as well. Your secretagogues, ibig sabihin it causes you to secrete insulin regardless of your current glucose level. These are your SUs, your glimepiride, gliclazide, or your meglitinides like repaglinide. Obviously, because secrete ng insulin, the side effects are hypoglycemia. Your incretin-based drugs, so your tides are again your GLP-1 agonists, your exenatide, liraglutide, semaglutide, or yung Ozempic na ginagamit ng mga tao pampapayat. A side effect is acute pancreatitis, and it is contraindicated in patients with a history of medullary cancer of the thyroid. Your gliptins are DPP4 inhibitors, and they can cause nasopharyngitis and upper respiratory tract infections. So the drugs that promote glucose excretion either through the P, which is your SGLT2I inhibitors, it inhibits the sodium glucose transport. It causes you to diurese out the glucose. So therefore, madaming glucose in your genital system, it increases the risk of UTI, genital fungal infections as well, like thrush. Your alpha-glucosidase inhibitor inhibits the enzyme in the intestines responsible for the breakdown of your complex carbohydrates into glucose, which it can absorb readily. So therefore, you have lots of unbroken down carbohydrates in your gut. So it makes sense na yung toxicity ay abdominal pain and flatulence or lots of farting. Second to the last, a patient is receiving bethanechol for her bladder issues. What side effect is most likely to occur? A, bronchoconstriction, B, mydriasis, C, hypertension, or D, constipation. So first of all, ano ba si bethanechol? Col, C-H-O-L. That should be your clue that it is a cholinergic agent. Okay, it is a cholinomimetic. So which of the following side effects is a cholinergic or a parasympathetic side effect? Our answer here is, of course, letter A. So mydriasis or widening of the pupils, that is a sympathetic side effect, not a cholinergic side effect. Hypertension is, of course, sympathetic, and constipation is also sympathetic. So guys, kapag sa cholinergic and your autonomic drugs, ang lalabas ay they will give you a drug, either cholinomimetic or anticholinergic. Pero yung tatanungin nila is not the direct indication for that drug, but rather what side effect is most likely to occur. So you have to remember your autonomic side effects very, very well. So remember, kapag parasympathetic, it's rest and digest. So ano yung mga effects of your cholinomimetic or parasympathetic agents? In the eye, it causes miosis or shorter diameter of your pupil. In the heart, it would cause bradycardia and decrease in contractility, kasi sympathetic is the opposite. In your lung, it would cause bronchoconstriction and increased secretions. In your gastrointestinal tract, so rest and digest, so definitely motility is increased and your sphincters are relaxed kasi ready ka mag-poops kasi nga you're resting and digesting. So definitely constipation would not occur. In fact, diarrhea would occur. Urinary bladder, ready kang umihi kasi you're resting and digesting. So your detrusor muscles are contracting, pero your sphincter muscles are relaxed, and your glands are very active. So your sweat, your salivary, your lacrimal, and your nasopharyngeal glands are actively secreting their contents. Last question for pharmacology. Which channel does gabapentin directly act on? Chloride, calcium, sodium, or GABA channel. So don't be fooled by the name gabapentin. It acts on your letter B, calcium channels. So your gabapentinoids, your gabapentin and pregabalin, they block the calcium alpha 2 delta channel. So the alpha 2 delta subunit of your calcium channel. This causes decreased glutamate release. So even if they have GABA on their name, they do not act on GABA channels directly. So which drugs do act on GABA channels directly? So this is your benzos and your barbiturates. So si choice D, which is GABA channels, this would have been the answer if ang tinanong ko ay a benzo or a barbiturate. Choice A, which was chloride channel, remember that GABA is a chloride ion channel. So therefore, benzos and barbiturates din yung choice A. Tapos choice C na sodium channels, that is the answer for most of your anti-epileptic drugs like phenytoin and carbamazepine, but not for your gabapentin, not for your pregabalin, because it is a calcium channel blocker. And that's it for your pharmacology.
All right, guys, now let's go into your surgery questions for the finals. First question in surgery, which of the following is not part of the rule of twos of mecyldiverticulum? A, under 2 years of age. B, 2% prevalence. C, 2 meters proximal to the ileocecal valve. Or D, 2 inches in length. So according to the rule of twos, ang hindi kasali dito ay ang letter C. 2 meters proximal to the ileocecal valve. It should be 2 feet proximal to the ileocecal valve. So be careful of the unit of measurement. So remember, the mecyldiverticulum is the most prevalent congenital anomaly of the gastrointestinal tract. It is the most common true diverticulum. Ibig sabihin, every layer of the intestinal wall is involved in a diverticulum. And the etiology is because of a presence of the omphallomesenteric duct. Now, it usually follows the rule of two, so 2% of the population. 2-to-1 male predominance, so twice more common in males than in females. It is found 2 feet, not 2 meters, proximal to the ileocecal valve. Half of the symptomatic patients are under 2 years old. 2 types of mucosa, it's gastric and pancreatic, and it is 2 inches in length. So of course, choice A, choice B, and choice D are correct. Choice C is incorrect, again, because it should be feet rather than meters. So remember that the rule of twos uses the American system, so uses feet and inches rather than the metric system. So this should be American because the English system uses centimeters and meters. What is the most important etiologic factor in the development of the primary adenocarcinoma of the esophagus? Is it A, smoking, B, Barrett esophagus, C, alcohol consumption, or D, HPV infection? So keyword adenocarcinoma, therefore our answer should be Barrett esophagus. So remember, this is a precursor lesion to adenocarcinoma. So if you do an endoscopy and you find Barrett's esophagus, that patient requires regular follow-up to ensure it doesn't develop into primary adenocarcinoma. Choice A, choice C, and choice D are risk factors for squamous cell carcinoma.
So remember to differentiate squamous cell from adenocarcinoma. Ang pinaka-common ang squamous cell carcinoma when it comes to esophageal cancers, whereas adenocarcinoma is more common in developed countries. So the usual location is the middle third of the thoracic esophagus. Sa adenocarcinoma, mas common sa distal esophagus. And that makes sense kasi adenocarcinoma usually arises as a progression of your Barrett metaplasia. So remember, Barrett metaplasia occurs with chronic repeated exposure to gastric acid. So nag-change ang iyong epithelial cells of your esophagus into the epithelial cells of your gastric mucosa in order to get used to the chronic repeated exposure to stomach acid. So nangyayari, nagiging columnar epithelium with mucosal glands often containing intestinal goblet cells. So syempre, whatever is closer to the stomach, which is the distal esophagus, dun mas nag-a-arise ang iyong adenocarcinoma. So yung squamous cell carcinoma, the lesions are usually plaque-like, erosive, or papillary, and they can be intraepithelial, intramucosal, or submucosal. So again, the most important etiologic factor in the development of primary adenocarcinoma of the esophagus is a history of Barrett's esophagus. And the hallmark of intestinal metaplasia to know na changes na ang iyong esophageal cells from squamous esophageal cells into columnar epithelium is the presence of your intestinal goblet cells. So again, choice A, C, and D are incorrect because they are squamous cell carcinoma risk factors, whereas choice B is the best answer. So what refers to the left axillary lymphadenopathy associated with gastric cancer? Is it A, the Irish node, B, the Virchow node, C, the Sister Mary Joseph node, or D, the Krukenberg node? So our answer here is letter A. So ang tanong is left axillary lymphadenopathy, and the name for that is your Irish node. So let's go through each of the other options. Virchow node is not axillary, it is left supraclavicular. Your Krukenberg tumor is a result of ovarian metastasis. Okay. Your Sister Mary Joseph nodule is a metastatic umbilical nodule, so you see it next to your umbilicus. And the Bloomer shelf, although not in the options, but good to know also, is whenever you do an intern or DRE or a digital rectal examination, you can feel a cul-de-sac tumor. Okay, so these are all signs of gastric cancer. So Krukenberg tumor is a tumor found in the ovarian cells. However, it is a metastatic tumor arising from gastric cancer. Next, winging of the scapula, which occurs after an MRM or modified radical mastectomy, is due to injury to the long thoracic nerve, thoracodorsal nerve, intercostobrachial nerve, or axillary nerve. So buzzword natin, winging of the scapula, automatically we have to think of your letter A, long thoracic nerve. So in a modified radical mastectomy or in any surgery towards the pectoral muscles, there's always a risk of injuring important nerves. So it's important to know ano yung mangyayaring signs and symptoms of damage to certain nodes. So kung long thoracic nerve, this supplies the serratus anterior, which is important for protraction of the scapula. So therefore, you would have winging of the scapula. Si thoracodorsal nerve innervates the latissimus dorsi, which is responsible for extension and adduction of the shoulder. So you would have limitation of these movements if you have a thoracodorsal nerve injury. Your medial and your lateral pectoral nerve innervates your pectoralis minor and major and pectoralis major respectively. And your intercostobrachial nerve is responsible for providing sensation to the medial upper arms. So if yun yung nawala sa patient after a modified radical mastectomy, it might be the intercostobrachial nerve that was affected. Next, what refers to a defect in the abdominal wall in which the bowel and solid viscera are covered by peritoneum and amniotic membrane? Is it A, gastroschisis, B, urachal cyst, C, prune belly, or D, omphalus heel? So our answer here is letter D, omphalus heel. Again, buzzword, covered by peritoneum and amniotic membrane. So remember, kapag omphalus heel, it is covered by a thin membrane. It can be ruptured in some cases, pero kapag sinabing covered by a peritoneum and amniotic membrane, think of omphalus heel versus your gastroschisis na walang covering. So it is directly the intestines na. Another difference differentiation is where the extrusion of the intestinal contents are. So if it is through the umbilical ring and central omphalocele, kung lateral to the umbilicus, often to the right, it is your gastroschisis. So again, let's look at this table. Remember, location, omphalocele derecho through the belly button, gastroschisis usually lateral, especially to the right. Yung fascial defect, it is variable. It can be greater or less than 4 centimeters. Pero sa gastroschisis, usually less than 4 centimeters lang ang defect. Yung sac, again, is always present or it can be ruptured versus sa gastroschisis na talagang absent. The intestines are usually normal in omphalocele versus sa gastroschisis na leathery and shortened. Yung liver is often herniated as well, so lumalabas din yung liver. In gastroschisis, it is rarely herniated. So kahit na sobrang pangit tingnan ng gastroschisis, it is actually the omphalocele that is usually associated with more chromosomal abnormalities and more abnormalities of syndrome. So cloacal extrophy, Beckwith-Wiedemann syndrome, and your Cantrell pathology, these are associated anomalies with your omphalocele. Things that are associated with gastroschisis include intestinal atresia, undescended testes, and malrotation of the gut. So see choice A, gastroschisis, again, has no overlying sac. Urachal cyst, hindi siya involved in the extrusion of the intestinal contents. It is instead the partial obliteration of the urachus presenting as a sac of tissue. Choice C, or your Pruin belly syndrome, refers to lax lower abdominal musculature, dilated urinary tract, and bilateral undescended testes. So dahil sa lax lower abdominal musculature, sobrang wrinkled tingnan ng belly nila, so mukha siyang skin ng prune, which is why it is called Pruin belly syndrome. And you remember, your urachus is present during fetal life. Ito yung connection between your bladder and your umbilicus. So if it does not obliterate completely, minsan may lumalabas na urinary contents from the umbilicus. So that is when the urachus is still patent. So it should obliterate as the baby is born as well. Next, which of the following forms the lateral borders of the Hasselbalch triangle? Is it the inguinal ligament, the inferior epigastric artery, the ilioinguinal nerve, or the internal inguinal ring? So our answer here is letter B, the inferior epigastric artery. So remember, the Hasselbalch triangle is an important anatomical consideration in hernia. So if you have a herniation within the Hasselbalch triangle, we call that a direct hernia, whereas those found lateral to it are usually indirect hernias. So remember the borders of the Hasselbalch triangle. So let's go through them. Laterally, you will find the inferior epigastric artery. Inferiorly, you will find the inguinal ligament. And medially, you will find the lateral border of the rectus abdominis. Okay, so if there is any herniation found within this triangle, they are considered direct hernias, and those found lateral to it are indirect hernias. Okay, so you see choice A, or inguinal ligament. This is not a lateral border, it is an inferior border. And choices C and D are not part of the Hasselbalch triangle borders. Next, a 30-year-old female taking oral contraceptive pills underwent an ultrasound which revealed an incidental finding of an asymptomatic solid mass. A CT scan done revealed a central scar. What is the appropriate next course of management? Is it A, observation, B, discontinue the oral contraceptive pills, resection, or D, biopsy and further workup? Okay, so first we have to figure out ano ba tong diagnosis na to. So CT scan revealing a central scar in a female taking OCPs. That should be buzzwords for what we call focal nodular hyperplasia, or FNH. So in a patient na asymptomatic with a focal nodular hyperplasia, the answer is letter A. Observe lang natin. So FNH is a solid benign lesion of the liver, and it is believed to be a hyperplastic response to an anomalous artery. So it is quite similar to adenoma. It's common in women of childbearing age, although the link to oral contraceptives is not as clear compared to adenomas, where the link is much more established. Ang buzzword natin dito is on CT scan, and FNH would appear as a well-circumscribed lesion with a central scar. So because its association with focal nodular hyperplasia is controversial, discontinuing OCPs is not the best answer. However, you can consider it if the patient was symptomatic. However, since a patient is asymptomatic and this is a benign lesion, observation is the only warranted management. We can also resect the lesion if the patient is symptomatic. Next, what is the most common bowel segment involved in volvulus? So is it A, the stomach, B, the small intestines, C, the cecum, or D, the sigmoid colon? So our answer here is letter D, the sigmoid colon. So the sigmoid colon, remember, is extremely mobile, it is redundant, and thus it is the most common site of your volvulus. So volvulus, if you remember, refers to twisting of an air-filled segment of bowel about its narrow mesentery, and 90% of all cases of volvulus are sigmoid volvulus because it is the most mobile and most redundant part of your intestines. Choice A, B, and C can all be involved in a volvulus but are at a significantly lesser incidence than sigmoid volvulus. So kung walang sigmoid volvulus sa choices, the second most common would have been cecal volvulus, which is choice C, and that approximates about 10 to 20% of the cases. Okay, so number one, sigmoid volvulus. Number two, cecal volvulus. So kung wala si sigmoid, look for cecal. Next, the Hinchy stage of diverticulitis with a pelvic abscess. Is it A, stage 1, B, stage 2, C, stage 3, or D, stage 4? So our answer here is pelvic abscess of diverticulitis, stage 2. So the Hinchy stage of diverticulitis helps us know how severe diverticulitis is. So diverticulitis is infection of the diverticula, which is mucosal outpouchings of the gastrointestinal tract. Kung diverticulosis, walang infection and the patient is usually not toxic looking. Pero if the patient clearly has an infection, elevated white blood cell, elevated inflammatory markers, febrile, unwell, it would be diverticulitis. So how does it present? It usually presents with pain at the left lower quadrant, alteration in bowel habit, and tenderness on palpation. So how do we stage it? We use the Hinchy staging. So syempre stage 1 to stage 4, from least to most severe. Kung stage 1, diverticulitis with a pericolic abscess lang. So a small abscess located next to the colon. So how do we treat or manage it? We can just do a percutaneous drainage of the abscess. Or if it's a bit more severe, you can resect the area that is infected with primary anastomosis without the need for a diverting stoma. So tatanggalin mo lang yung affected bowel and then you would anastomose it together. Kung stage 2 naman, it's not pericolic anymore. Mas distant na yung abscess. So it can be retroperitoneal or pelvic. So look for those words, retroperitoneal or pelvic abscess, stage 2. So again, it could be either percutaneous drainage or resection with primary anastomosis, or sometimes kailangan ng diverting stoma. Stage 3, more severe. So hindi na kaya ng percutaneous drainage. Kailangan na ng Hartmann procedure or diverting colostomy plus percutaneous drainage. So this is used in patients who are highly unstable and who cannot undergo a major procedure like a Hartmann's procedure. Stage 4, kung fecal na yung peritonitis, ibig sabihin there's already fecal matter causing the peritonitis. So again, same management as well. So again, let's look at some pictures to really help hammer it in. So remember, stage 1, quite localized. It's diverticulitis with a pericolic abscess or katabi lang ng colon, quite near to the colon. And these outpouchings are the infected and inflamed diverticula. Stage 2, remember ano yung buzzwords natin? Pelvic and retroperitoneal abscess. Stage 3, peritonitic na yung patient and it's purulent, so full of pus. Stage 4, fecal peritonitis. So it is fecal matter. Because of usually holes in the colon causing fecal peritonitis, and that is the most severe form of your diverticulitis. So stage 4, pericolic, pelvic or retroperitoneal, purulent peritonitis, and fecal peritonitis. Next question, what is the initial management for a low-grade gastric lymphoma? Is it A, complete resection, B, radiotherapy, C, chemoradiation, or D, H. pylori eradication? Our answer here is letter D, H. pylori eradication. So it is the first-line treatment for low-grade gastric lymphomas. So this is what we call a MALT or a mucosa-associated lymphoid tissue. So remember, the stomach, normally it is devoid of lymphoid tissue. However, in response to chronic inflammation, this mucosa-associated lymphoid tissue can arise. And in low-grade lymphomas, H. pylori eradication represents the first-line treatment because it is H. pylori that causes MALT in the first place. So choice C, or chemoradiation, we reserve this for advanced low-grade lymphomas or in high-grade lymphomas. And surgery, we reserve this for very urgent situations of tumor complications. So for example, if the tumor is very large, causing severe acute obstruction, then we would consider surgery. The first line for this cancer is H. pylori eradication. So remember the different methods or the different regimens to eradicate H. pylori, like your OCA, omeprazole, clarithromycin, amoxicillin, and next, thyroglossal duct cysts are the most common encountered congenital cervical anomalies. Which of the following is a surgical management of a thyroglossal duct cyst? Is it A, the Ramstead procedure, B, the Nissen procedure, C, the Sistrunk procedure, or D, the Whipple procedure? So our answer here is letter C, the Sistrunk procedure. So what is a thyroglossal duct cyst? So remember, it is residual thyroid tissue left behind during its descent. So during fetal growth, the thyroid gland doesn't actually start here in front of the trachea. It starts at the base of your tongue from the foramen cecum, and then it travels down into the anterior low neck. So sometimes there is a vestigial remainder of this tract, and when that is left behind, it is called a thyroglossal duct cyst because normally it should obliterate during fetal growth. So that typically presents as a subcutaneous swelling near the hyoid in the midline or slightly paramedian. So again, 80% will present below the hyoid bone. So one unique thing about this mass is it moves with both deglutition or swallowing and tongue protrusion. Kasi diba, the path is from the base of the tongue and the foramen cecum. So the treatment of this involves removal of the cyst. You also remove the tract, so from the base of the tongue down to the neck, and the central portion of the hyoid. So this en bloc resection is what we call the cyst trunk procedure. So the rest of the choices, choice A, Ramstead, is not for thyroglossal duct cyst. It is for hypertrophic pyloric stenosis. Choice B, or Nissen, is used for GERD, and choice D, or Whipple, is used for pancreatic head masses. Next, in the management of a solitary thyroid nodule, based on the Bethesda criteria, what is the next step if FNAB reveals atypia of undetermined significance? Is it lobectomy, near total thyroidectomy, or repeat FNAB? So our answer here should be repeat FNAB. So generally, if any biopsy, so FNAB is fine needle aspiration biopsy, if any of it shows results na undetermined significance, so for example, pap smear na undetermined significance, biopsy na undetermined significance, look for repeat the test in the options kasi most likely yun yung tamang sagot because we don't know whether it was a negative or a positive result. So the Bethesda system it has diagnostic category to say whether it is Bethesda 1 or Bethesda 6. So let's go through them, and it has different management based on the Bethesda classification as well. So kung Bethesda 1, it's non-diagnostic or unsatisfactory. So in this case, you should repeat the FNAB with ultrasound guidance. So unsatisfactory, pwedeng hindi sapat yung sample na nakuha natin during the aspiration biopsy. Kung Bethesda 2, that's benign. So we would just do critical follow-up. Kung choice 3, yung sinabi nating atypia of undetermined significance. Or follicular lesion of undetermined significance. So there is some abnormality, but we don't know whether or not it is significant. Therefore, the best thing to do would be to repeat the test. Kung Bethesda 4, that is a follicular neoplasm or something that is suspicious for a follicular neoplasm, we would then do a surgical lobectomy, so just part of the thyroid. However, if we are suspicious for malignancy or if it is really malignant, we would do a near total thyroidectomy. So see choice A, or lobectomy, so we would only do that for Bethesda 4 or follicular neoplasms. Choice B, or near total thyroidectomy, we would reserve for Bethesda 5 and Bethesda 6. And again, choice C, total thyroidectomy, is given only for Bethesda 6 or confirmed malignant nodules. A palpable femoral pulse indicates that the systolic blood pressure is at least 60, 70, 80, or 90. So kung nakakapapa yung femoral pulse, that is at least 70 millimeters mercury. So buzzwords kung carotid, 60, kung femoral 70, kung radial 80. So imagine the more distal it is from the large arteries, kung nakakapapa, it means it requires a higher pressure for you to be able to feel it. So carotid, quite proximal to our great artery. So 60, femoral, medyo malayo na, radial, sobrang layo. So 60, 70, and 80. Next, a 35-year-old pregnant woman was alarmed when she noticed blood dripping when she defecates. She also noticed a non-painful anal mass that reduces spontaneously. What is your first consideration? Is it A, first-degree internal hemorrhoids, B, second degree, C, third degree, or D, fourth degree? So ano yung keywords natin is she can see or note the painful anal mass and it reduces spontaneously. Therefore, the answer is letter B. Kasi kung letter A or first degree internal hemorrhoids, she would not be able to see the fleshy hemorrhoids kasi grade 1 hemorrhoids do not go past the anal verge. So remember the grades of your internal hemorrhoids. Grade 1, it protrudes through the anal canal but not beyond the anal verge. Grade 2, it protrudes beyond the anal verge pero it reduces spontaneously. Choice 3, kailangang i-manually reduce ng pasyente. And grade 4, even if the patient is trying to manually reduce the hemorrhoids, hindi niya kayang gawin. So it cannot be reduced. So from increasing from low to higher grade of severity. Next, what is the most common location of the tip of the appendix? Is it A, retroperitoneal, B, retrocecal, C, pelvic, or D, parailial? Our answer here is letter B, retrocecal. So that is the most common location of the tip of the appendix, followed by pelvic, followed by retroperitoneal. So the appendix, remember, is a true diverticulum of the colon, and it is thought to be an immunologic organ. It is thought to secrete IgA. It is supplied by the appendiceal artery, which is a posterior cecal branch of the ileocolic artery. And grossly, we can trace where the appendix is by tracing the convergence of the tinea coli in your colon. So it is usually intraperitoneal, and the most common location of the tip is retrocecally. So again, the second most common is pelvic, where 30% of it occurs, and retroperitoneal, number 3, or third most common, where 7% of the tip of the appendices are found. Next, a patient with rectal carcinoma underwent distal removal of the distal colon, rectum, and anal sphincter using abdominal and perineal incision, resulting in a permanent colostomy. This procedure is known as A or AN, A APR, B LAR, C TME, or D transanal excision. So our answer here is APR, or abdominoperineal resection. So remember, this resection involves resection of the distal colon, the rectum, and the anal sphincter using exactly an abdominal and perineal excision. Kaya siya tinatawag na abdominoperineal resection. It is also, because you are radically removing all of these structures, it does also result in a permanent colostomy and technically, or most often, a worse quality of life. Okay, so again, APR is abdominoperineal resection, includes the resection of these organs, and because you are removing all these vital organs, you require the construction of a permanent end colostomy. So when would you do an APR, even if it tends to portend worse outcomes? We do this if there is perianal skin involvement from the tumor, if there is puborectalis and sphincter involvement, or if there is fecal incontinence. See, choice B or LAR, which is low anterior resection, does not involve a permanent end colostomy, usually temporary colostomy or ileostomy lang. See, choice C or total mesorectal excision, TME, does not include the mesorectum, or includes the mesorectum in the excision. So sa choices kanina, walang sinabing mesorectum. And choice D, transanal excision, is only used for small rectal tumors. So hindi siya en-bloc resection kagaya ng APR mo. Penetrating abdominal trauma is an example of what type of wound? Class 1, Class 2, Class 3, or Class 4? Kung penetrating abdominal trauma, automatically Class 3 wound na yan. So remember the different classes of your wounds. Kung clean, clean contaminated, contaminated, or dirty. Kung clean, we do not enter the genitourinary, gastrointestinal, or respiratory tract. So examples are hernia repair. So kahit na intestine siya, wala ka namang vinaviolate violate na integrity of your gastrointestinal tract. You're usually just putting a mesh over the defect in the abdominal wall. So a hernia repair can really be thought of as an abdominal wall surgery or breast surgery. Clean contaminated, sometimes you do enter the GU or the GI or respiratory tract. For example, a uncomplicated cholecystectomy or an elective gastrointestinal surgery na hindi colorectal. So, pwede siyang 2A or 2B. So, 2B is colorectal surgery. Kung contaminated class 3, this is when there is major breaks of sterile technique or inflammation causing introduction of bacteria. So, syempre, penetrating abdominal trauma would count as contaminated. Large tissue injury, or enterotomy during a bowel obstruction. Now, dirty or class 4 is overt infection. So things like perforated diverticulitis, which is Hinchey class 4, di ba? Fecal peritonitis, or necrotizing soft tissue infection. So sobrang lala na ng infection. What is the overall most common indication for splenectomy? Is it A, ITP, B, myeloproliferative disorder, C, trauma, or D, splenic abscess? Overall, the most common is still your letter C, trauma. So trauma is the overall most common indication for splenectomy. So remember, your spleen is important as an immunologic organ, and therefore patients without a spleen are more prone to infections from Neisseria, Streptococcus, and Haemophilus, which is why patients who are about to go a splenectomy, kung elective or planned, dapat may vaccinations sila 2 weeks before, or kung emergency, dapat 2 weeks after. So choice A, ITP, is the most common hemolytic anemia, which splenectomy is offered for. Choice B and D are also indications for splenectomy, pero hindi sila ganun ka-common. Next, what is the most common organism associated with pyogenic liver abscesses? Is it A, staph, B, strep, C, escherichia, or D, bacteroides? Our answer here is letter C, escherichia, particularly Escherichia coli. So it is the most common pathogen associated with pyogenic liver abscesses. It occurs in 2/3 of cases. E. coli ang ating culprit behind most of your pyogenic liver abscesses. So in terms of pyogenic liver abscesses, 40% are monomicrobial. Ibig sabihin, isang bacteria lang yung ma-isolate mo. 40% are polymicrobial and 20% are culture negative. So in these cases, you would treat with broad-spectrum antibiotics for 8 weeks. Choice A, B, and D, so C. staph, strep, and C. bacteroides. Yes, they can also cause pyogenic liver abscess, but they are far less common. Last question for surgery. Which of the following criteria for a positive finding on diagnostic peritoneal lavage for abdominal trauma is incorrect? Is it A, RBC of greater than 100,000 per ml, B, WBC of greater than 500, C, amylase of greater than 9, or D, alk phos of greater than 2? So abdominal trauma, incorrect dito ay ang ating amylase of more than 9 IU per international units per liter. Kasi the correct answer should be more than 19 rather than more than 9. So let's review the different criteria kapag nag-diagnostic peritoneal lavage ka for anterior abdominal versus thoracoabdominal. So okay, magkaiba ang anterior abdominal and thoracoabdominal. So in terms of red blood cell count, mas strict ang criteria for anterior abdominal. Kailangan more than 100,000 ang iyong ma-meet na criteria versus thoracoabdominal na 10,000 lang. So in this case, kasi abdominal trauma, tama ang letter A, which is more than 100,000. White blood cell, more than 500 for both. Amylase, more than 19 for both. Alk phos, more than 2 for both. And bilirubin level, more than 0.01 for both. Okay? And that is it. All right, that's it. Those are all the questions for your surgical examination.